Welcome back, everyone. We're ready to get started. We also have to remember to adjust the mic height if you got some short people. We're ready to get started. We wanted to say thanks again to our sponsors, the Paramedic Foundation, the SAVIC Foundation, Mobile CE, Physio Control, Paramedic Health Solutions, Image Trend, Crestline, and General Devices. So for those of you that aren't from the U.S., you're going to hear from a group from California now. California is like another country. It operates completely differently than the rest of the United States. They have some unique nuances, and we're going to hear about some of their challenges, the work that they did, and the results. So Lou, we'll let you take it from here.
Well, good morning. Actually, afternoon, because we did eat, right? All right. Well, I'm pleased to be here today to present the California Community Paramedicine Pilot Project, and I am the project manager for the California Emergency Medical Services Authority that has the oversight of all the programs that are taking place in California. I also have the privilege of working with two dynamic individuals, Dr. Janet Kaufman from the University of California, San Francisco, and Dr. Karen Shore with Gold State Health Policy. So what I'm going to do is just give you a quick overview of the community paramedic structure and what we had to do to get to where we are. Dr. Kaufman is the actual independent evaluator for this project. So she's going to give you the data, the research side, and Dr. Shore is going to give you some case studies where she actually went out into the field and spent time in the field with the community paramedics. So it takes a village. These are the organizations that are involved in the California Pilot Project. Some of them are public, some of them are private, and a number of hospitals and also local emergency medical services agencies. So the California Health and Safety Code really limits how a paramedic can function or advanced care paramedic can function in the state. So they're able to the delivery of emergency medical care to the sick and injured at the scene of an emergency. This is the key word, at the scene of an emergency, during transport to a general care hospital, during interfacility transfer, or while transitioning at the emergency department. And in no other area can they practice their craft. So when we want to do a community paramedic pilot project, we had to find a way to get a waiver of that health and safety code regulation. And in California, there is some legislation through the Office of State Health Planning and Development that allows for pilot projects, health workforce pilot projects, to take place. So we explored whether or not we could use this mechanism to get a community paramedic program approved, and after 1,000 pages of an application and proposal, OSHPD approved the state of California's ability to do pilot projects. So I've already talked through that, we'll just move on. So our community paramedic projects are a collaboration and partnership to address identified gaps in the care, and the interesting thing is that, or what we wanted to make sure is that we were filling a gap and not replacing services already being provided by others. So it was not intended to duplicate or compete with others. And paramedics would receive additional education, training, commensurate with the focus of a CP program. So those were the initial requirements set forth. There's 14 sites throughout the state of California. As you can see, they're pretty evenly divided amongst the state. Not as much rural area as we had hoped for initially, but actually we have an additional 7 pilot projects proposals currently under consideration that does drift up into some of the rural areas of the state. So the types of projects that we are dealing with were the post-hospital discharge. You've heard a lot about that today. Frequent EMS users, also heard a lot today. What you haven't heard about is directly observed therapy for tuberculosis patients. Community paramedics actually go out into the field and find the hard-to-find tuberculosis patients to make sure that they are in fact taking their medications. Also, we're doing hospice support. This is where a community paramedic goes and responds on hospice patients. Hospice patients that are enrolled in this program are loaded in the database at the communication centers, and if a 911 call comes from their residence, the community paramedic responds with the 911 crew, and in most cases is able to stay with the patient until the hospice nurse arrives and a transport is actually not taking place. Also have alternate destination to mental health crisis centers. This is where community paramedic makes an evaluation in the field, medically clears a patient to go directly to the behavioral health center rather than going and bogging down the emergency department for 6, 7, 8 hours or a couple days. Alternate destinations are urgent care centers. This again is where paramedics in the field, specially trained paramedics, they are not all community paramedics, but specially trained paramedics who we better called alternate destination paramedics with special training, triage patients to whether or not they needed to go to an ER or they could have their situation dealt with in an urgent care center. And Dr. Kaufman's going to talk a little bit about this one, but this one never did get legs. While, in my opinion, paramedics can triage patients to EDs and to urgent care centers, the urgent care centers in our areas were just not ready to take on this type of a workload. And then we have our alternate destination sobering centers. Similar to the behavioral health, patients are assessed in the field of whether or not they just need to go to a sobering center for their situation, or they in fact need to go to an ER and again sit in the hallways for a number of hours. So our additional requirements for the IRCP program was that they have to have an independent evaluator. That's where Dr. Kaufman comes in. You had to have an institutional review board approval from your partnering hospitals and universities. Patient consent was required. Patient consent was waived on the mental health side under a certain section of the federal law. And oversight for public safety with an immediate notification of myself as well as the medical directors for any possible risk situations. So with that, a lot of our program required data to be submitted to the UCSF, and this is where Dr. Kaufman is going to take you forward.
So thank you very much, Lou. It's a privilege to be here with all of you. And in fact, Lou, I think we're just about celebrating our 4th anniversary. Well, no, you've celebrated yours. I am in terms of the evaluation, because it was October 2013 that our team at UCSF was selected to do the independent evaluation. Lou had been brought on board earlier than that. In fact, and I would say Karen did the first major work on community paramedicine in our state in the sense of authoring a paper laying out, well, what is community paramedicine and how might this be helpful in our state? So I'll just talk a little bit about the evaluation methods, a high-level overview of our findings. I'm not going to get into much depth on any concept. Karen will be diving deeper into the post-discharge projects and the alternate destination mental health and sharing what she's learned from her case studies. And then we'll talk about our conclusions. This is going to cover the projects through June 30th, 2017. We have the projects report to us on a quarterly basis with a lag, so we'll be getting the data through September out toward the end of the year. So methods. So we do ask the sites to report data to us on numbers of patients enrolled, the provision of community paramedic services. You know, tell us about what you did. The cost of providing services and the cost of ambulance transfers. The state, one of the requirements for the independent evaluation is to assess what the cost of care is under the model you're testing and how that compares to the cost of care under the traditional typical way of doing things. And we've also then mined existing sources of data on hospital readmissions, the cost of ED visits, and hospital admissions. And now I'm sure none of you who work with hospitals will be shocked, but the hospital partners didn't really want to share real cost data. In fact, some of them were quite vehemently opposed to that. So we said, okay, well, how about this? You all have to report some data to the state anyway on hospital discharges, including your charges. What if we use that? And then we use some other sources of data on ED visits. And then we supplement, the data are tremendously important, but it's always, I think, as an evaluator, important to supplement that with conversations with key people to give yourselves the context for the data. And so we've done interviews and conference calls with Lou, with the pilot project leaders at each of the pilot projects. We've talked to community paramedics, we've talked to partners. So we also, our team also did a set of site visits to each of the projects. And that was very, I think, very important for getting the context and getting a wider range of perspectives. So what did we find? Well, before the findings, just to sort of walk you through the timeline. So I came on board in October 2013 as the independent evaluator. The application went to the state in December of 2013 for approval for the pilot projects. That went through 2 cycles. We'll spare you the political details, but the projects were authorized November 2014, and then we had to get the community paramedics trained. And I don't have a slide on this, but they all did a common training on community paramedicine that was video conference live up and down the state. And then each of them also did site-specific training. And that involved, okay, if you're going to do directly observed therapy for tuberculosis, what is the pathophysiology of tuberculosis? How do you treat tuberculosis? Why is directly observed therapy so important? How do you use motivational interviewing and other techniques to, specifically deal with folks with this particular problem? And then they also went and intentionally met people at the partner agencies. So that's November to June 2015 and beyond. June 2015, the first projects go live. Tuberculosis in Ventura County, which is down near Los Angeles. Post-discharge in Alameda, which is across the bay from San Francisco. Most of the projects then are live by October 2015. Then in February 17, our last project, the Alternate Destination Sobering Center, went live. They did not apply to be part of the pilot in the first round, but came on board. Well, they were approved in November 2016, came on board in February 17. And as Lou has mentioned, there are about 7 projects now under consideration that may be added. So these are the data on enrollment. As of June 30th, 2017, a total of 2,185 have been enrolled in the 14 projects. And if you can see up there at post-discharge, where we have 5 projects, that accounts for over half of all of the folks enrolled. 1,327 out of 2,185. And actually, a lot of those are at one particular site that has enrolled a large number of people. The directly observed therapy for tuberculosis is the smallest, partly, I think, because, fortunately, tuberculosis is a relatively rare condition. The alternate destination urgent care, despite having 3 sites, only has had an enrollment of 48. Several projects have closed. One of the post-discharge projects was discontinued in August of 2016 because the partner fire department was unwilling to support it. One of the alternate destination urgent care projects is closed, and the other 2 will close by November of this year. So patient safety, this is clearly a very important consideration for all of us in healthcare, and particularly here when you're trying something new. So our conclusion from interviews, from data, from reading reports that the pilot sites submitted to Lou in his role as project managers, we really felt that none of the patients enrolled experienced adverse health outcomes. And then if anything, there was some evidence to suggest that there really been some benefits in terms of patient safety. So one area was medication reconciliation, which I know we've talked about a lot at this meeting, but that definitely, particularly, this happened primarily in the post-discharge projects. A lot of these are folks with multiple complex conditions who didn't understand they're doing. One of my, I think our favorite story is a gentleman with congestive heart failure who had 3 scripts for Lasix, one from the hospital, one from the PCP, one from the cardiologist. He thought he was supposed to take all 3. So 3 times the dose of Lasix recommended for him. Fortunately, the community paramedic caught it and said, no, only one. We've also had issues of folks, we talked about, our Colorado colleagues talked about refills this morning. Definitely folks coming out of the hospital with 7 days of meds, 30 days of meds, not always understanding that to manage their illness, they've got to continue to take that medication daily. A lot of referrals for housing, social services, behavioral health services, primarily for the frequent EMS user project, but also for post-discharge. And then the alternate destination mental health, one of the things that came out clearly when we talked to law enforcement in that county was this is actually a win for law enforcement. So a lot of the folks that are part of this project are folks that are on an involuntary hold. We call it a 5150. You all probably call it in your state whatever the appropriate applicable statute is. And so these are folks that under the traditional way of doing things, unless the police thought there was a medical need, it was on the police to go to the emergency department, sit there with the patient, wait for the patient to be accepted by the ED. And so sometimes they'd spend several hours just sitting around in the ED with the patient. So now they can activate the community paramedics. The community paramedics can take charge of the patient and decide, well, is this a person who's an appropriate candidate for going to the crisis center? Or is this someone who is also intoxicated and the crisis center won't take them? Somebody who's got a medical need? Is it somebody we need to send to the ED? And so it's freeing up the law enforcement officers to call back in and go out on more law enforcement calls, and that's a win for them. Now, so while we would say there are no adverse outcomes, there definitely have been some secondary transports to the ED. But not that many. About 4% of the alternate destination mental health folks were transported due to things like agitation, hypertension. And in that case, most of those transfers were in about the first 3 months of the project. I would say that's a case where the medical director for the EMS agency was very engaged with the medical director of the mental health crisis center, and they worked with one another. It's like, okay, can we get really good agreement on a protocol on who's in, who's out, so that every time we transport to your door, we know you're going to accept folks. Sobering Center has had about 2%. In talking with them, I think there was maybe one case where the paramedics did not make the best use of the information available to them in the field about transporting the patients, but the other were things around alcohol, withdrawal, and confusion that weren't necessarily evident. And indeed, the literature in sobering centers, while limited, suggests that there's going to be a subset of patients who, based on what you see in the field, you can't fully predict who's going to really need to go to the ED versus be safe in the sobering center. About 4% for the urgent destination also, that was really truly a secondary transfer in the sense that the urgent care center had accepted the patient and then decided to transfer them. But we did have 9 other cases of what we would call a continuous transfer. So the paramedic, the ambulance brought the patient to the urgent care center, and the docs at the urgent care center said, no, we don't think we can take care of this person here. You need to send him to the ED. And it was for various reasons. Some of it was unavailability of equipment. The X-ray machine happened to be broken. that day. That's kind of a fluke. But some are things like dislocated shoulder, where you're not exactly clear that you would absolutely have to take that to an ED, but the urgent care centers were not comfortable taking care of those folks. Okay, talk a little bit about effectiveness. These are the inpatient readmissions within 30 days. I'm not quite sure how days got cut off there. But these are, what I've done is I've arrayed them by the diagnoses: heart failure, AMI, COPD, pneumonia, and the projects. In the middle, we have the historical 30-day readmission rate. So this is taking the Medicare hospital compare data and looking at what was the historical rate prior to July of 2015. We wanted a benchmark that was prior to the time that we started implementing. Then this is the percentage of folks enrolled in the pilots who were readmitted, and just the numbers, so you can kind of see the scaling of the numbers. So in the majority of cases, there's a statistically significant difference between the percentage of folks enrolled in the projects who were readmitted and the historical rate. Now, in truth, a lot of these hospitals are doing other things at this time to address readmission, so I don't know that we can totally attribute it to the CP interventions. But some of these differences are stark enough that I think it's fair to say that the CP programs at least played a role. We have one, Butte up here, where the proportion of enrollees readmitted within 30 days was actually higher than the historical rate. What's different about the Butte project is that their protocol calls for them to speak to folks on the phone and then only make a home visit if the paramedics think that that's really necessary. All of the other projects, there's at least one home visit, and they've all clearly done better. So I think going forward, if we add pilot sites in California like we're contemplating, anybody who does post-discharge, it's certainly our advice, and I think EMS agency's advice is you've got to do at least one home visit, that we've got a sense that that's really necessary to have an impact. We've also seen reductions in ambulance transports and ED visits for the projects with frequent EMS users, hospice patients, and persons with mental health needs. That these are all cases where transports and visits have been avoided. In hospice, there have no doubt been some inpatient admissions avoided. Alternate Destination Sobering Center reduces ED visits for intoxicated, inebriated persons. Doesn't reduce transports, because there you're transporting to sobering instead of ED, but you are getting folks to a more appropriate level of care, and the turnaround time is somewhat faster. San Francisco doesn't seem to have quite as big of an issue of wall time in the ED as some of our other places, but even though so, it is a benefit that you can get the person triaged sooner. And at the sobering center, all they do is take care of folks with acute alcohol intoxication, whereas in our EDs, particularly our level 1 trauma center, those folks are they're never number one on the priority list. This is just to show you for the hospice project. So prior to the pilot, about 80% of the hospice patients who called 911 ended up transported to the ED. During the pilot phase, for the folks who were in a hospice that participated in the pilot, only 31% were transported to the ED. I think from talking with folks and looking at the data, it's never going to drop to zero. Some of these are folks who have falls where you need to get them to the ED to at least x-ray, and in some cases they're going to need surgery. It's unrelated to their hospice diagnosis. Other cases, the person, even though they signed up for hospice, at the time of that 911 call, they're really adamant that they want to go to the ED and revoke hospice. And so it's never going to be zero, but I think what they have done is eliminated some of the ED visits that were not desired by the patients. I already kind of talked about this, obtaining care more quickly, but basically for the sobering center and the mental health crisis center, you're bypassing the ED. You're going to a place that specializes in the needs of these folks and can assess them and get them started on treatment faster. Better medication adherence in the TB project, and this is partly community paramedic knowledge, but mostly community paramedic availability 24/7. So this project, the community paramedics are paramedic supervisors. So they're on, somebody's on duty, several somebodies are on duty in the county 24/7. And because they're supervisors, they're not responding to every 911 call. They've got some time on their schedule. And so they go and visit these people. In contrast, the way the county had previously done all of their directly observed therapy was with community health workers who only worked weekdays during business hours. And that has worked well for some people, but they've had, for example, this is a bedroom, Ventura County is a bedroom kind of county community of Los Angeles. And so there's folks there who, have long commutes. It's not convenient for them to be in Ventura County during the workday. And so the paramedics were dosing them 9, 10 o'clock at night when they got home. Some of these folks are folks who are homeless, undocumented, otherwise marginalized, some with significant mental health or substance use issues. And they're not the easiest people to care for. But the paramedics, they've only, as far as we can tell, they've only missed 2 treatments. They just have really been out there, been available, been assertive, and also said to people, okay, how do we make this work for you? We'll do it when we can make it work for you. Referrals to a wide range of services. I'm not going to read all of this, but just to give you a flavor for the wide range of services to which the CPs have referred people. A little bit on savings here. We definitely see reductions in ambulance transports, ED visits, and inpatient admissions. And so this yields savings for health plans. The largest share is accruing to Medicare and Medicaid. We asked the sites to report on payer mix, and the majority are Medicare or Medicaid beneficiaries. We also see some savings for hospital. The post-discharge projects, as I said, have by and large reduced 30-day readmissions, so that's lowering the hospital's risk for Medicare penalties. And then the frequent EMS users, a lot of those folks are uninsured. We in California have made some of the greatest strides to increasing the proportion of our population that is insured, but this is a marginalized population that struggles to get insurance even today. And so by diverting these folks, getting them signed up, taking care of their, stepping back and saying, what are their social needs and how can we meet those outside of the ED? They're cutting back on the number of uncompensated ED visits for the hospitals, so that's also a win for the hospitals. So what have we concluded? So I think we've seen from all these projects that paramedics can provide services beyond the traditional and current statutory scope of practice, that they've improved well-being. We didn't find adverse outcomes. No health professionals displaced, and I don't have time to get into it, but definitely as we went around and did our interviews, we had conversations with some of the partners, particularly the nurses, that went something like this. Well, I was a little skeptical of this at first. Actually, I was really, really skeptical. But we got to know them. We worked some hospice calls. We worked some post-discharge placements. And I could see that we could work together. I was afraid they were going to go all cowboy on me and start doing things that really were beyond the pale, but no, they're really being good partners. One thing that has helped, I think, in 2 cases is that the EMS agency running the CP program has a nurse who's on the staff who has been the main liaison with the nurses at the hospital. So they, nurse to nurse, they can talk to each other. And the CPs, too, I think have really, been thoughtful in how they've worked with nurses, social workers, and others as well. And as we said, mostly yielding savings. So I think we have, now that the post-discharge frequent EMS, user tuberculosis, hospice, and alternate destination mental health, those have been up, most of them now by running for at least 2 years, that they really are safe and effective and are making a difference. Our initial findings from the Sobering Center are also suggestive that that project's safe and effective. The urgent care, I would agree with Lou there. I think our urgent care centers were not quite ready for prime time on this. This really, and as several folks said to us, well, you've got to understand, Urgent care centers are used to seeing ambulances pull up and take people away. They're not used to ambulances driving up and leaving people there. I think also just with the low volume, I think our paramedics there did not get the same ability to practice and implement. I think all of our other projects, there's been enough more volume of patients that the paramedics have gotten more comfortable, gotten better at it. Maybe a little less so the sobering center, but definitely the others. And to me, it raises the question, how much can we implement this alternate destination model that relies on training sort of the whole EMS, all of your first responder paramedics versus a more traditional CP model where you have a select group, not only with additional training, but hopefully folks who are really themselves really embrace the role of community paramedic. And with that, I think I will turn it over to Karen, and hopefully I didn't take too much time.
Hi, good afternoon, everybody. Delighted to be here. As Janet mentioned, ooh, that's interesting. I wasn't expecting that to look like, it didn't look like that earlier, it was blue. As Janet mentioned, I had the opportunity about 5 years ago to go to a meeting in Atlanta on community paramedicine. That was my first foray into the community paramedicine pool, so I'm very appreciative of the folks who were there at that meeting, several of whom are here, and also those who did work that was presented there that we have all learned from. So, as Janet mentioned, I was a co-author on a paper where we took sort of what we had learned from reviewing the literature in the US and internationally, and how could California tap into this neat idea of community paramedicine, and we recommended the pilot projects be implemented, and voila, they were. It was amazing. So the California Healthcare Foundation has supported a lot of the work in California around community paramedicine, and about a year ago, I was asked to write up a couple case studies to really delve into the details of what's going on in these sites, both to share with other communities who might be interested in putting these kinds of programs into place, as well as to inform policymakers. So to really lay out the case for community paramedicine, a particular topic or a particular community in a way that they could connect with. So the two case studies are going to be on the Alternate Destination Mental Health Crisis Center. So this was a case study that I worked on last year, and it's in two communities that are about an hour east of the San Francisco Bay Area in Stanislaus County. So two cities there with about 280,000 people altogether. So again, the paramedic evaluates to see whether people can be transported to the mental health crisis center instead of to the ED. And then the second case study was a little bit different. So it was 5 different sites that are all doing the post-discharge work. So as we've all talked about, the Medicare penalties is a big driver for this, and the tremendous interest in getting people from the hospital to home safely. We are actually also working on a third case study on the sobering center concept for San Francisco, where EMS is partnering with the sobering center, and as Janet was alluding to, training both community paramedics to work in this space, as well as we're calling them alternate destination paramedics, to confuse the vocabulary even a little bit more. And those folks get less training and are the ones that are responsible for screening patients to take them to the sobering center. So I'm not going to talk about that in any detail today, but if people are interested, the case study will be done in a couple weeks if all goes according to plan. Oh, goodness. Oops. So this is a lovely photo. This is not exactly what's supposed to be on the screen, but the photo was supposed to be there. This we actually borrowed from another community paramedicine program across the country. But in this site, there are 4 full-time community paramedics and then 2 alternates, and amongst them, they provide 24/7 coverage in these communities. So they also kind of split their roles. They also serve as first responders, and they partner with the county's behavioral health program as they're working to implement this pilot project. So the county has both the mental health crisis center as well as an inpatient psychiatric facility right next door, so in the same physical location. What you would see there, if the slide was spelled out are the goals of this pilot project, primarily focusing on improving care and using resources more effectively, but really getting folks who don't need to go to the ED to an alternate setting that's better for them, freeing up resources in the ED for people who have acute medical needs, helping, as Janet was saying, with law enforcement being able to get back to their duties more quickly, and working for overall health system savings. So I think was mentioned that the program was limited to individuals who are enrolled in California's Medicaid program known as Medi-Cal, or to patients who are uninsured. So at the time, this was just the way that things could work out with the various partners. Was not an intention to exclude people with private insurance. But as you can see from the criteria here, the program is really for folks with the mental health psychiatric issue and not having any significant acute healthcare needs. This is not a reading test, although it may appear to be one. So I am happy to tell you that I did bring a few copies of the case studies if people are interested, and also it will provide a link at the end so you can get it online and you can blow up the font on your screen so you can actually read it. But so there's about 3 different ways that a patient can be considered for this program. Someone can call 911, they can come in through law enforcement, or they can walk into the crisis center themselves. So once the patient is identified as a possibility for this program, the community paramedic is called to the scene and does 2 assessments. One is a physical health assessment, and the second is a mental health assessment. If they pass both of those and have the right insurance status, again, uninsured or on Medi-Cal, the community paramedic will make a call to the crisis center and sort of explain the patient that they're working with and that they would like to bring them there. If there's a bed available, that's the kind of a rate limiting factor here. So the bed has to be available and the patient agree to be transported to the mental health center. Then they are then taken by the ambulance, so not the community paramedic, but the ambulance transports them to the crisis center for evaluation and treatment. So they might get admitted to the inpatient facility that's right there, or they might have some time in an observation unit, or be referred to community resources or discharged home, a variety of options for destination there. But if the inpatient facility is full or the patient does not make it through the assessment, the 2 assessments, if they have private health insurance, then they're taken directly to the ED. I'm actually going to skip over the outcomes because Janet talked about that. And she has more recent data than I do. But we wanted to talk about some implementation challenges and as well as the secret sauce. So we're on a mission to find the secret sauce in these. So we weren't really looking at the outcomes. We were focused on putting the program in place and what was difficult and what worked well. So people have talked about data and the challenges around getting it and being able to match it up and share it and that kind of stuff. But really the biggest factor for this pilot site was the limited inpatient mental health capacity at the psychiatric hospital that was on the same campus as the crisis center. So I think there were 23 beds or something like that. Yeah, about 20, so 20 low 20s beds, and a lot more demand than could actually go there. So there was a private psychiatric hospital in the county also, but they were not participating in the pilot. So there, a lot more need that could be met if that private hospital could also get on board with this. So some of the secret sauce was a visionary medical director who's really committed to this and sees community paramedicine as a solution for their community. Of course, the skill level and the commitment after being trained up of the community paramedics. The medical director was very effective at getting all the stakeholders in this community excited about and committed to this program and all the different types of organizations that you see there. And then also having the crisis center and the inpatient psychiatric facility in the same area was perceived as helpful. For other communities thinking about these programs, we asked folks in Stanislaus County what they'd recommend. So preaching to the choir here, but designing the program based on what the greatest needs are in the community, training and recruiting as many community paramedics as you possibly can, and then of course focusing on sustainable funding sources. And I wanted to share this quote from the medical director that I mentioned. It's Kevin Mackey, who is with the Mountain Valley EMS Agency. I won't go into all of those words, but really he basically said community paramedicine is a game changer for their community and also for healthcare overall. So very positive assessment of this program. So switching gears a little bit to the post-discharge short-term follow-up. So again, there would be more words on that slide, but they are missing. I don't know where they went, to the black hole of somewhere. That's okay. So again, there were 2 cities and 3 counties that are involved in this particular model of pilots. And here, the community paramedics make either a phone call or a visit or both within 24 to 72 hours of people being discharged from the hospital. So like the folks in Cleveland, they perform a variety of services. So they do a medical assessment to see if you need any care before the next scheduled medical appointment. They review the medications, do medication reconciliation for people. They go through their discharge instructions with them to see if they understand what they're supposed to be doing, what the next steps are, and when they're going to go back for follow-up care. They also do environmental assessments for hazards and safety to make sure that there aren't rugs or that the light bulbs are working and that kind of stuff. Some also provide referrals for community services that would be helpful for people. And then also some said that they counseled folks on their lifestyle changes that they could make around nutrition and exercise and that kind of stuff to help them manage their conditions. So the overall objective of these pilots was to reduce the number of patients that were readmitted to the hospital after a stay, and then of course the penalties, and to improve quality of care for some very vulnerable, fragile patients. I'm gonna skip more data slide. So I did want to talk a little bit about the key characteristics of the sites and how they differ. So again, there were the 5 sites. You can maybe, if you're sitting in the front, actually read some of those words, but the 5 different agencies that were involved in these sites really varied in the number of paramedics that they trained up, so, and had working in this program. So in UCLA, see if I can get the, there was 1, and then in San Bernardino, 13. So, but ranging in between there. But the staffing model was really different in the different sites. So some places had a full-time, committed community paramedic or 2 or more, whereas others had these folks do overtime to provide community paramedicine services or work on a part-time basis. So a lot of variability there, and you can see kind of in the staffing model the details of that. And then 2 or 3 of the sites, I think, had just 1 or 2 visits. This is a short-term follow-up visit. So this is not home health where you're getting 2 or 3 visits a week. This is really short-term, help you stabilize after you're out of the hospital. There were a couple of sites in Alameda and Solano County, I believe, that would provide more visits if they were needed and beneficial. So this is how, again, people got into the process. For 4 of the sites, there was a hospital discharge planner who was really kind of screening people and reviewing for eligibility, and would ask the patients to consent. And once they agreed, that person would provide the community paramedic with information about that person and their follow-up contact information. At the other site, the community paramedic was actually in the hospital all the time. So he was doing rounds with the care team and really getting to know the patients in the hospital and saying, hey, I'm going to see you in a few days when you're discharged from the hospital. So getting to know him while he was there. So patient gets discharged from the hospital, and then kind of what happens, a couple different models here. There were 4 sites that do it one way and 1 that does it a different way. Not the same 4 as it on the first split, of course, but you can see the different counties or cities that did it which way. For 4 of the sites, the community paramedics would call the person within 24 to 72 hours and say, hey, we want to schedule a visit and come see you. Let's set that up. And at the other site, as Janet was mentioning, it's a very rural area in Northern California where there's a lot of need and not a lot of paramedic resource. So they would call the person on the phone in that same time period, but not to schedule a visit necessarily, that they had an algorithm where they would use to see whether patients should be seen that day by a paramedic or whether they could be seen within a couple days or whether they would have the phone call only. So as Janet said, the majority of what they were able to provide there was the phone-based consultation. So the challenges in these sites, there's more challenges because there were five sites instead of one, but having it being a pilot project, it was difficult to get funding. It takes a while to establish relationships, as we all know, right? You can't just say, oh, we're gonna work on this starting tomorrow, let's all go. You have to spend time getting to know people and what their motivations are. And a couple people said that they felt as though they were being asked to build the program as they were implementing it. So that's challenging. I guess that's like for yesterday, we were flying the drone, or building the drone as we were flying it for this group. So another challenge was around data exchange, and not all the partners here had electronic health records, so that made data exchange complicated. There were also not enough community paramedics, and there was a need for some multilingual paramedics in some communities. And then there were some interesting challenges around patient participation and dropout. So there were a couple sites that focused on heart failure, but they had a lot of young folks with heart failure who were using methamphetamine. So those patients would initially agree to be seen by a paramedic after they left the hospital, but when the time came to schedule the appointment, they either weren't available by phone or, oh yeah, maybe, no, we're good. So much more reluctant to let uniformed people into their home subsequently. The secret sauce for the post-hospital visits, again, a lot of the same things we talked about earlier, but one of the things that really jumped out here was that the community paramedics, as they were going through and seeing whether the person had more needs right now, they could actually call up and talk with primary care, specialty care, home health, and get advice about the person and make appointments for them as needed and referrals to the, for home health. So for other communities thinking about this, several considerations, but the ones that maybe we haven't focused on quite as much around the planning stage. So one of the things people pointed out was it's really important to have specialists whose expertise, clinical expertise, is tailored to what you're working on. So if you're focused on heart failure, maybe an orthopedist isn't your medical director choice. So that's a bad example, but you know what I mean. And then in terms of the implementation, funding is a big issue, and I think there's a lot of interest in the shared risk / savings arrangements that people have talked about. And if the health plans and the hospitals are going to benefit from these types of programs, let's get some funding from them. So, and then finally, encouraging interaction among these paramedics and, kind of where are they going career path-wise and training and professional development. And a couple quotes here. The first is from a hospital administrator about one of the post-discharge programs who is, I think she was, as maybe John had alluded to, the skeptic early going on, but really found that as they worked with the paramedics that this was getting better patient care and saving resources for them. And then the second example is really about how a community paramedic was thinking outside the box. So they were working with a homeless patient who had asthma and wasn't taking care of herself very well. So they ended up asking one of the local businesses if she could plug in her nebulizer there so she could take better care of herself and avoid going back to the ED. So that's kind of the wrap up on the case studies, and look forward to answering any questions. And again, I do have a couple or some copies of the two that are completed if people are interested. We wanted to share some resources with you. So from the EMS Authority, there's a description, or you can go there and find a description of the pilot program and the sites and track down Lou, right? And then the UCSF site has the evaluation report and lots of other good stuff, and you can find Janet there. And then the California Healthcare Foundation website has the 2 case studies that are done, the third one that'll be coming, and then some other materials that people might find interesting. I wish we'd had a thought to share a 2-minute video, might be too much, but it's a really neat interactive, not interactive, but animated video that describes community paramedicine and kind of the cool things that community paramedics do. So if people are interested in that. There was also a briefing in early 2017 that was held in Sacramento that these 2 fine folks presented at, and that video of that briefing and their materials are available there too. So that's it for us. Thanks, everybody.
We're doing good on time. We're likely to move Pierre after Charles because our break stuff comes out at 3 o'clock, so we don't have anything to give you until 3 o'clock. But we'll just play that by ear, but it looks like we're going to get out of here fairly early today. So one of the things that I get to do is I'm Chief Commissioner of the American College of Paramedic Executives. And this guy I've been able to give 2 credentials to this year, a supervising paramedic officer and managing paramedic officer. And hopefully next spring he'll become a fellow of the American College of Paramedic Executives. So Charles, congratulations on those 2 achievements.
Thanks, sir.
And today he's going to lead us through a talk about collaborating with hospitals, ACOs, and managed care organizations. Thank you.
Where's my driver? Here. All right, good afternoon. I'm glad I wasn't the one after lunch, so hopefully you've had a time to stretch your legs and empty your bladders and get ready to roll. Collaborating with hospitals, ACOs, and MCOs, may need to turn me down, I'm a little loud. I looked at this as on an international basis, and everybody has different titles for it, whether it's a hospital, a national healthcare system. ACOs, accountable care organizations, and managed care organizations are a little bit different and more unique to the United States, but they do have their place in what's coming. And when we talk about what's coming, we're going to mention that just a little bit with some of the international realm of healthcare improvement. So this is our logo. We are not a full-fledged department. We're still a pilot project, and we started over 6 years ago. So what we're going to talk about next are basically a lot of the headaches, the scars, the injuries, from running into walls, from having doors slammed in my face, and from having people go, that's a really great idea. Second question, who's going to pay for it? So how do you get past that point? So this is where we are located in North Carolina. We're in the western section of North Carolina in the mountains. It's a very rural area. It's very diverse and spread out. We cover 18 counties. We're the regional tertiary care facility. Our health system is responsible. We have 6 hospitals. But we're responsible for all the population within these 18 counties. And we'll get more about population here in a minute. This is our community care medic team. We have a couple in the room. Randy Fugit and Chris Brackett are with us today. And our partnership is, as you see it there on the screen, it's actually with Mission Health Partners, who is our accountable care organization. And it was that organization that allowed us to get started, that funded the pilot project, funded us coming here today even, and their care coordination team. And as we will talk more about data later, but it's really all about the medical records and performance measures, the 33 metrics, for example, for ACOs that they need data on. So what are our special tools? Well, everybody has their toolbox. But there's some important things of tying in on the back side of community paramedicine. So it's not just the medic making the visit in the home, it's what happens after the fact. So part of our uniqueness is we're tied into a pod system where we actually have a care coordination team, and they follow up with these patients. They're assigned based off of, for example, our ACO has about 75,000 lives under its responsibility umbrella. They're broken down into different medical practices, and for each practice group, they're assigned into one of these pods. So we have our care management, we have a social worker, we have the pharmacy tech, but we also have that piece of that health data exchange that we talked about earlier. When Jonathan was speaking, he was talking about that centralized language of information. We have that piece in place. We're a Cerner shop for our hospital, so we have that access into the chart as well, which is another uniqueness that can help you a lot in your programs. And then we also have access to put that same EHR working into our new Athena population health software, and we have access into those charts. So a lot of what we talk about, the need to do studies and research and things like that, requires access to data. Well, if you don't have access to the chart to put things in, you're definitely not going to have access to take stuff out on the backside. So that's one of the first reasons that you need to be partnering with your organizations in your area. So This is kind of what our management pod lot looks like. This is not a completely unique idea. It was stolen from our Medicaid pod models, Pathways Hub system from several years ago. There's a recent article published by our medical director for the ACO, Dr. Fields, in North Carolina Medical Journal. I have that information, so when the slides are published later, you'll be able to see that. But what's unique about it is the fact that these are all shared resources. So we share our community paramedic resources with their care management pods, and we work together to provide a solution for patients. And that's the thing that's really important, is your partnership with the hospital, the healthcare foundations, the organizations in your area that are the main providers of resources for patients. You need to be part of that process. So what have we done with our project? Everybody's put their data up here today. Here's what we did. Here's where our increases, our decreases were. We actually had initially started a nice little study. Our ACO changed software in the middle of it, and then the software company that they went away from, which was a good thing, they kind of went downhill. And so now in order for us to get data from them, we have to do an individual SQL query for every single patient. So that kind of shot our initial study in the foot, but we're going to restart with the new software. So yes, we got a reduction in our ED clientele. We got a reduction in inpatient admissions, our reduced readmissions. We all know this. We've seen this all 3 days here. In study after study, program after program, we put our numbers up. But one of the key things, if you look at our numbers in the bottom right and the bottom corner of the slide, so you go, wait a minute, there's different numbers for different groups. That's right. If you try to run your study across your entire population, you're going to fail, because the data is individual to the individual patients. And some patients aren't being admitted. They're not in the hospital, so that you don't have to worry about readmissions. They may only be an ED patient. You need to be able to break down your data when you're approaching hospitals. They're going to drill down this far, and they're going to ask those difficult questions. So you need to be prepared for that. What is this all about? Well, just like anybody else, you know, I said you can see one community paramedic system. Well, this is what our patient demographics look like. We took the top 3 DRGs, we broke it down. So yeah, there's a lot of behavioral health, there's COPD, there's CHF. So you have to drill down into your patient population for your health system to see what actually applies. We talk about our risk scores, and we'll get into this in a second, but a MERA risk score, they say that a high-risk patient is a 4. You can see the average of our patients was 16, so that's a fairly high-risk patient. Our actual per member per month charge about $2,000, but this Milliman Advanced Risk Adjusters looks at a lot of different things to capture what the actual risk is of the patient. What is this patient's chance that they're going to need your services, really, is what it's looking at. Because if they're a high-risk patient, they need support services, and you're that support service. Along with knowing that particular part of the puzzle on your patients, we also need to know what our potential impact score is. Because if you have a stage 4 cancer patient, are you really going to make a difference in the outcome of that patient? If that's all you're using in your studies and you're taking that data to a hospital, you're not going to be successful. Look at patients you can make an impact with. There's your impact. And no, I did not miss a decimal point. Those are all commas. This report was just released. They unembargoed it in their official language right at the end of Friday morning. But in the last year, with our accountable care organization, for a Medicare population of 47,536 patients, we saved $11,236,413. Now that's real numbers. That's real savings. That, my friends, is making a difference. Now, is that all community paramedicine? Absolutely not. But here's the beauty of our partnership with our accountable care organization and partnering with hospitals that see the bigger picture. They realize that we are an integral part of that system. And as the senior VP that's over this project says, it is the synergistic effect of every program that we have that makes this happen. Our care management model, our support services, our partnership with nonprofits outside of us, and also our partnership with other programs from the YMCA to even a legal aid service that we have. All right, so it's a lot of different partnerships. But we're actually bringing back a shared savings performance payment of over $5 million to the organization. Now, if you can show your contribution to this, and you can say that you're part of this bucket of money coming back to the healthcare organization, do you think they'll allow you a seat at the table? Yeah, that's what it's really all about, getting that seat at the table. How do we get there? Well, the first thing you need to do is learn the words, the language, the conversation points, and the vision of healthcare executives. Not what we believe in the EMS world, not what we believe in the academia world. It is, what do they talk about? If you're in the United States, it's kind of easy because there's actually an American College of Healthcare Executives. You can go get their magazine, and you can read some of the articles. You can read Modern Healthcare, Becker's Journal. There's a lot of different informational websites out there for your area, no matter where you're from. But you'll learn the TLAs and FLAs. Anybody knows what TLAs and FLAs if you're in the military, you know? 3-letter acronyms and 4-letter acronyms. Yeah, we got a ton of those in EMS. But guess what? So does the hospital world. And if you're going to sit in a meeting with them, you need to know what they're talking about. Because just like we have our own little language, somebody pointed out, we do this kind of maybe to mess with rookies coming in. Well, the healthcare world has their own language. And you need to be able to understand it and speak it when you're sitting at the table. So what are their buzzwords? I can tell you, at my organization right now, the buzzword is capacity management, throughput, moving patients, or regions talk about it as patient days. Everybody has their terminology for it, and it's different in every organization. That's another key point. But what are the industry trends for the healthcare industry? And we're going to talk about one of the big ones coming up, but knowing what's going on in their world so you can know how to apply your tool to help them fix their problem. So some people have kind of jokingly referred to the IHI Triple Aim Initiative. Folks, that's the Bible. It's a religion. Can I get an amen? I tell you what, you're sitting at a healthcare executive, you'll get an amen because this is what they study. This is what it's all about. This is where performance measures and metrics and quality came from. And for those of you that think, okay, well, that's that crazy American system, no, it's not. Because IHI has been doing a lot of travel. They've been in England, they've been in Scotland, and they've been in Germany just within the last 6 months, working on healthcare improvement in those areas as well. It doesn't matter what your funding model is, whether it's private insurance, whether it's a social system, you need to have these measures. You need to be focused on improving the health of the population, improving their experience, that customer satisfaction score, and you need to be reducing the per capita costs for care populations. Now, we talk about this experience of care, and we asked a question earlier about customer satisfaction with the prison program with UC Health when they were talking about their halfway house, all right? We don't take that serious enough. We've got to get to the point. I mean, how many of you have walked in the bathroom since you've been here and seen those little smiley faces? Did you notice that? Yeah, on the way out of the bathroom, you can hit a little smiley face and you can tell them whether you're happy with how clean the bathroom was or whether you're unhappy. We have those in our ambulances. Well, actually in the hospitals they do. In fact, there's a little device when they first started doing customer satisfaction, customer experience scores, the patient experience, where they actually had these little handheld devices they gave the patients to score the system. It's that serious. So another thing as part of your study when you're looking at your health organization in your area, look at their values, look at their aims, look at their vision statements. And look, right there inside the bigger aim, to get every person to their desired outcome without harm, without waste, and with an exceptional experience. Sound like the triple aim? Yeah, it's just worded a little different. It's our statement. That's where it all applies. That's what it all boils down to. And I think when we heard the Regions presentation the other day, they referred back to some of their statement and using that as a tool. It's important. You've got to see what their focus is. It doesn't matter what kind of focus you had when you came in there or what your nail looked like. Yeah, you're bringing the hammer to the game, but you need to know what their nail looks like, not yours. All right, so these are some things that IHI is actually working on now. So this is not from the past. This is on their current website. You can go to this, you can find it, and this is what they're taking. And I talked to some of the folks that were in the group that traveled overseas, and they're trying to find new models of population health management. Hey, we got one. Hello, over here, community paramedicine. Look at us. Are we talking to anybody about that? Are we reaching out to our hospitals to tell them how we can do this? So there's a lot of campaigns that are coming, and what they're looking at is they want to reduce disparities and inequities of care. And when they're looking at this, they're looking at populations that we serve on a regular basis. They're looking at socioeconomic factors. We can help with that. We can be participants in fixing that problem. Now, how many of you have ever referred patients to housing or helped them get housing? Is housing a medical treatment? Is it? Yes, it is. It's found to be, in many cases, the ways to eliminate problems with healthcare access. And just recently, in one of our cases, we actually picked a patient up and moved them. Literally, the care management coordination team, one of our care medics, picked this patient up and moved them. Loaded a truck up, got the dollies, moved the patient into this place. And now they're in an apartment center where they're actually now, instead of being socially isolated and not being close to anything, they can get fresh vegetables, they can get a food market, they can walk and access people and have conversations, even though they do go hang out at the smoking pit to have that conversation. But still, it's a step in the right direction. So those are the things we've got to look at. So we extend reach and impact, building capacity for skills. Do we not already have something working with that? Do we not have a curriculum that we're building for community paramedicine on multiple levels? We already heard that presentation. That's what we need, and we can apply that to IHI's initiatives. So when we talk about comprehensive quality strategies for nations and other large health systems, are we part of the quality metrics? We talked about the study that's in the process right now. How do we do quality and assurance? How do we self-regulate if we don't have quality and assurance measures? What is important in that factor? If we can be part of a quality assurance process and performance metrics, we can be a part of IHI, a part of the triple aim, which means we can be part of a much larger picture of healthcare and improving things for our populations. So here's the big thing. We heard an excellent presentation on how things are working in Dubai and how quickly things are getting implemented and all the great tools they had, including the really racy first responder cards. And I did already put my application in for that. I'd love to do that. I didn't want to do the unmanned or the manned drone thing, but I'll do the car. But here's the thing. In order to move faster, what do organizations need? You got to have money, you got to have vision, you got to have support. You can help with that because you can provide some support, okay? You can be part of the future vision. So systems and processes. This is a really thing that I learned from our Chief Innovation Officer. Dr. Wessel always talks about this. Anybody can build a widget, whether it's the FirstNet or whether it's the Beyond Lucent Technologies, Image Trend. That's a widget by itself. What's important, and the way you make things work for everyone, is you take that widget and you develop a very solid system or process, a workflow that has proven to be successful in a healthcare setting. That's when you get people's attention, and that's where you make a difference. We're partnering, for example, with Thomas Jefferson University, Mount Sinai Hospital, for a hospital in the home project, just like Regents mentioned that they're working on, okay? Those are important things to be part of those kind of processes so that you can be a system, and as a member of that system, you get recognized. And now you get to work in other areas, but you've got to participate. And there it is, that big data thing. Folks, big data is a necessary evil. If you're not capturing the data the right data and you're not inputting data on their side, you're not valuable. The value is in your data. For example, one of our big values to the Accountable Care Organization are the 33 performance metrics. How many people in here can give flu shots? You just checked one of the 33 performance metrics for an Accountable Care Organization. They are now happy. Sold. It's that simple. Can you prove that you got those flu shots to this patient and give them a patient name, date of birth, and a medical record number? We can do that, right? We have that technology. It's a wonderful thing. What about shifted patient outcomes? The focus is on what you're doing. The focus is on what we do with the patient at a final stage. It's not about transporting the patient. We've got to get away from that mindset. I mean, I curl inside every time we have to say that we're from, a subsection of the Department of Transportation, okay? That's not what we do. And if we want to move forward, we've got to look at how to focus on patient outcomes. How do we be a part of that? How do we model into other systems within the healthcare system already existing? They want to see that management leads the model of healthcare, not just clinician-driven, but it's about a business now. And you need to be part of that business prospect by being a tool, a support, an actual adjunct to what they're already doing. All right, we talked about this again. If you've got the money, we saw where Dubai already had a seamless medical record system. They put it all together. And that's a great way, and that's a future vision of where we all should be. How do we create that? And whether it's through an interface, we have a health data exchange tool that we use to try to create that, to share data back and forth. Whether you're actually charting in their system, some of the folks have mentioned that there's an Epic system they're charting in. I know our counterpart across the other end of the state in Hanover Regional Medical System, they chart in Epic. And they've created kind of a community paramedic platform. But you've got to be able to share that information. And this is the other thing we talked about. We've got to standardize what we do. It can't be this county does that county does that, this state does that, this region does that. What are we doing internationally, across the board, as a community paramedic? What are our care process models? What have been proven to increase patient outcomes? What are they? Have we done studies on that? Have we looked at it from that perspective? And then the big thing is embracing the metrics. We've got to be able to measure. Several people put up slides talking about measurement. You don't know what you're doing. If you're not measuring it, you don't know what the outcome is. So clinical performance. And again, harp again on patient satisfaction scores. Can you provide them? Do you have access to a tool? Do you know how to get access? Can you match that up against the hospital scores? And then you're going to have to give up your cost factors. That's already in legislation now for EMS that we're going to have to share what our actual cost is, our cost of operation. Hospitals have to do that every year. They have to show what their cost of operations are. If you're going to get money, you're going to participate with them, they're going to want to know what your costs are. Do you know what your unit of service cost is? If you're saving $200,000 a year from reducing ED visits, but if your cost is $175,000, that's not really that big of a win. But do you know that? Can you bring that to the table when you have that conversation? The next step is kind of really important, especially in the United States, and although there are some international accreditations, I didn't have time to capture all of those, but we have different accreditations, we have commissions, there's certifications, and verifications that hospitals have to achieve. Has anybody here ever been invited to an interview for chest pain accreditation at a hospital? Yeah. You have to have EMS at the table in order to get that award, okay? That accreditation doesn't happen unless they talk to somebody with EMS in your community. So if you've got programs of care, like for example in our hospital world in the U.S., they have the Joint Commission that kind of oversees making sure hospitals follow the rules, right? Well, Joint Commission also has accreditation, for example, COPD. We participated in one of those with our respiratory department, and they looked at the community paramedic program, and they're like, wow, this is an amazing concept. And it was the first time this person had ever been exposed to that. So now they're running around championing to hospitals that you need to have a community paramedic project with your COPD program. It's like this really great idea. So you can create champions for yourself if you sit at the table. All right, so everybody knows about CHNA. We've talked about that. Hennepin tells you that when you're, as our paramedics went through the course, you got to do that community health needs assessment, right? It is really important and it's really individualized. But here's the important part for you. If you want to partner with a hospital, an organization, accountable care, whether it's a managed care organization, it doesn't matter. You need to know what their pinch points are. You need to do an assessment of what that local hospital is. Don't look at national trends. Don't look at province, state, regional. Those aren't going to help you. And again, this is one of our scars. We worked as a committee for 4 years before we got a pilot project. And one of the first things we attacked, we went to all the Matt lectures, went to all of Dan's lectures. I talked to them and bugged them all the time. They had this really great program on CHF. And we got all excited. We put all our eggs in that basket. We got our CHF program all geared up. We modeled after there. Here's the success. Here's the money you could save. And this little lady that you would look at like either an elderly librarian or older teacher walked into our meeting. It was great. We got up there and we did our little song and dance, and we were all happy, and we were like, ta-da! You do know that Mission Health has a 4% lower than the national standard average of readmissions in CHF. We have a very successful program. We're actually modeled by many other partners within the state. Okay. Well, round two, here we go. So we didn't do our research. We didn't look within our own organization that we had access to get the data. We made that mistake. That's why I'm sharing it with you. Look within your own organization around you, your hospital, even if it's your own hospital. It takes a while to find this information out. They don't just publish it, trust me. And then get into a department level focus. And what I mean by department levels is start, when you're dealing with a hospital, start with one department. Don't attack the whole hospital. Don't go sit down with the CEO. Figure out which department is having the most problems that you can help, whether it be the emergency department, whether it be case management, whether it be CHF, COPD, a respiratory therapist, whatever it is. Focus on one service line, one department. And believe me, once you prove your success, then they're all knocking on your door. Today we have department after department calling us up going, hey, by the way, can you come talk to us about how you can help us with this community paramedic thing? Like, okay, but that goes to the ACO now, so you have to go through them to get to us. They're the gatekeepers. And of course, our ACO senior VP goes, there'll be a small charge for that. Unit of service cost, interdepartmental charge. So when you look at these things the right way, you can get your start and go from there. And again, the key point, forget your bias of what you think is going to work. Forget your bias of what works for you within your community. Granted, you got your frequent flyers, you got your other programs within your own service. That takes care of your needs. Focus on what the hospital healthcare organization needs. Take your bias out of it, listen to what they're saying, go to their meetings. And the biggest thing is focus on doing the greatest good for the greatest number of patients. Where are you going to make the biggest impact? Impact is important. You've got to be able to make an impact. You've got to be able to show change. And with that, you've got to make sure that you have a target you can show change with. Again, don't pick something that you can't be successful at. Take time to do the research. You know, I got really worried when we got into year 2 of the committee and all these folks excited about the program, and we were just not going anywhere. And all these other programs were popping up, and every time I went to a conference, there were like 10 or 12 more programs around the country that were popping up. And it's like, we're missing it, we missed the bus, we missed the bus. And I got some really solid advice from Dr. Ed Rock when he sat me down and said, don't be in a hurry to fail. Take the time and do your homework. This is our chance in EMS as a profession to get this right. And I took that to heart, and luckily I did because it took us quite a while before we moved on. So I'm going to throw up some other opportunities here in the United States. If you're dealing with a hospital, these are all the hospitals that, for example, got mandated to have a comprehensive care plan for joint replacement. which means it's a bundled payment. The hospital gets a bucket of money, simple way to look at it, simple mind, simple thing. A bucket of money to pay for this joint replacement. They distribute the money. If you don't sit at tables and in meetings with them, how big a part of that bucket of money do you think you're going to have? They don't even know you exist. If you're there up front and you're able to meet with them and show how you can contribute to this patient going back to a safe home and not having to go to a skilled nursing facility and them having to pay that charge, now you bring something to the table. Your community paramedic can go visit that person, can check on them, can be available to follow up with them. These are all services that these kinds of programs are looking at. And folks, if you're an EMS in the United States and you think that, hey, but we're part of Medicare, we bill Medicare, yeah, we're like a couple percentile. We're a very small portion of it. The hospitals have the big buckets. That's where we need to go in any area. The biggest reimbursement's always going to the hospital. We need to partner with them to be successful. This is just an example of different models and all the things related around bundling improvements, but basically that's your bucket of money flying down the road, and it's going to somebody else if you don't step up to the table. I remember, I think it was the other day, with one of the groups talking about going to meetings. Yeah, I don't see my office very much. And if you're going to get involved with a hospital, you're going to go to a lot of meetings. But your first meeting could be something simple, getting involved with an emergency department. Getting your foot in the door at any meeting. Say, hey, y'all have a high utilizer group? Because we got this patient we think is probably on your list. Could we kind of partner up to do something about this one patient? Start the conversation with something simple. Get into one of those committee meetings. Now, our system was growing. We decided we were going to have this big logistical, basically an emergency operations center for patient movement throughout the whole hospital. They started this vision group. They started talking about all the different things that need to be in it. And because we had went to our chief innovation officer, and they had seen some of the success of the program through our accountable care organization, and we'd sent some of those great patient stories up the chain, I'm sitting in a meeting and our paramedic coordination pops up on the screen. I was like, wow. I didn't even put this slide together. We already got our name up there. But meeting after meeting after meeting to get to that point. It didn't just happen by me presenting one time. Went to a lot of meetings. I still go to a lot of meetings. So what are hospitals into right now? Anybody doing telehealth? Because hospitals are. That is a really, really hot topic. There's some legislation here in the States going through. It's going to make it even easier for them. We just bought the product SWIMED on the left because of the technology and the software involved. But we've got 2 units now so that when the hospital says, hey, can y'all help us with our telehealth program? Well, we're already connected to the telehealth program. And they have these other tools about remote home monitoring. I've heard a couple of people talk about having devices that actually measure patients' different vital signs. But they also have a tool where the patient records every time they take a medicine. They click a box. They can click a box and ask a question. But here's the thing. They have these great telemedicine, telehealth tools. Guess what they don't have? They don't have anybody to respond. Here's the gap that you can fill. They need a response mechanism. They need somebody that can go follow up with these patients when some of these things don't go through. They miss an appointment. Maybe they're in early discharge. We talked about our hospital at home being one of the things that we're working on with the alternative payment model. But they have to have somebody to follow up. We are that person. We are that opportunity. We can be that piece of success for them. So this is a really big area of growth. If you're looking at how you're going to mint yourself up inside your healthcare system, this is a really good opportunity. Telehealth, telemedicine is a growing thing. It's really big in organizations right now. If you have a rural organization, they're using it in a lot of ways already. This is your tie-in. Be the boots on the ground. So I just want to show a couple of futuristic things, talk about vision and what we see in our region, in our area. We already heard about levels of community paramedic. We already set in play to do some educational training in our region to provide that, so that not only do I have the 8 community paramedics that we've trained, but we have others within the EMS agencies within our counties. so that we have someone that we can work with. Training community responders, whether it be EMT, firefighters, first responders, people that work in industrial complexes that are responders. Put them as part of your program. Because if we really want to get somewhere, we want to make an impact on people and population health, we need to quit talking about ourselves as emergency medical services. We are not EMS. It's not an emergency anymore. We waste time half the time we run emergency. We do acute care. We do specialized care. We make a difference in people's lives. What do paramedics do? I'll tell you what paramedics do, yeah. They can tell if they're sick or sicker, but you know what they can do? They can walk in the door, and because of who they are, have enough respect for them to open that door on the other side as they come on in. They can have that conversation. They can sit down at some of the worst places in town, some of the most rural places, and they can have those conversations. That's what paramedics offer. And that's what the same level of coverage can offer. We start talking about, we can cover your population. We can take care of the health of the population in our district because we can go out, we can see them, we can take care of them, we can follow up with these patients. And in the end, you have public health awareness participants. This can be your little old ladies that go to the Bridge Club, church organizations, senior citizen centers, school teachers, just so they know what to look for. And then that also feeds to the other side, and I know I don't see Dan in the crowd, but Dan had this really great patient that they basically did a lot of work with, and this elderly patient is now doing really well, and guess what? They're talking about giving her a phone and letting her call some of the other elderly patients so they get away from that loneliness factor. You beat the loneliness with somebody who wants to talk to somebody else because they both need somebody to talk to. Wow, simple solution. And we see that every day with the patients that we touch. We know who those people are. We know who the talkers are, all right? Because it takes us 30 minutes longer to get out of their house than it does some of the other clients, all right? We know that. And, you know, I'll be the same one, I'll be honest with you. When I get old, y'all going to have a hard time getting out of my way. Let me tell you this other story. Hold on one more minute, one more story, all right? But public health awareness participants, just another level to look at population health coverage as a total district of coverage. I mean, this isn't a novel idea, folks. I'm not some visionary future brainy person. I stole this from the fire department. I mean, think about it. The fire department has a district, right? Everything in that line, when you draw that line around that district, what do they got to do? They got to put the fire out. Doesn't matter if it's a rat on fire, a dumpster, a car, a house, a condominium, or a big industrial complex. They got to put it out. It's in their district. Why can't we establish the same thing in population health with community paramedicine? Why not? So the last thing, this is just a personal pet peeve of mine, the missing aim. We talk about the Institute for Healthcare Improvement, the triple aim, but it's really important that we improve the experience for our community paramedics, for our caregivers. Because there is a thing, even in this business, in the business of community paramedicine, called compassion fatigue. And you see this day after day with patient day after day, and they're not doing well. You need to be able to improve their experience because you want to keep these folks. You don't want to burn them out. These are the best of the best. Isn't that what we all said? We got really experienced people, and we put all this extra training in them, and they do really great things with these patients. But wait a minute, we got them on call 24/7. They know to call their community paramedics number. They need a break too. So make sure we watch as we grow this internationally. We look across, we set all these different levels, that we take care of that clinician. We make sure that they have an improved experience and that they are taken care of. Info, if you have any other questions, if we don't get to them at the end here, I'll leave that up for y'all.
Okay. We have a little extra time, so I'm going to use chair's prerogative. Don't do this very often. I'm going to do a little intro for Pierre's session. one that I did at work not too long ago. And I mainly want to talk to the people from the US today, but I think the rest of you will get something out of this. You've all seen that things are done a little bit differently in other places, and you've seen good things and places where you could improve. But I want to talk about some things that are really timely here. So I'm going to show a series of pictures, and what I want you to do as fast as you can is shout out the name of the profession that belongs to the picture. And the first one is easy because it's on the side of the vehicle, okay? So as fast as you can, shout out the profession. Okay? Okay, now this next one is, it's good Ann isn't here. This next one's a little bit sexist, but it will get the response that I need. Okay, and? Okay, we're in a good room. When this slide comes up, lots of different names pop up. EMT, advanced EMT, intermediate EMT, ambulance officer, paramedic, advanced care paramedic, lots of names pop up. So when we think about the public and what they think of us, this is a newspaper from one of the ambulance services where I work in St. Cloud, Minnesota. Here's what the public in St. Cloud, Minnesota knows us as. The ambulance workers. That's who we are, the ambulance workers. And what do people call us that we really hate? Ambulance drivers. Ambulance drivers. But you know what? We haven't given them any other term, have we? And what do they see us all do? Drive the ambulance. That's what they see us do. So when this picture came up, you could have said officer, corporal, sergeant, lieutenant, captain, investigator, chief, trooper, or detective. But you didn't. You said police officer. When this picture popped up, you could have said lieutenant, captain, pump operator, driver, district chief, inspector, prevention officer, hazmat specialist, firefighter 1, firefighter 2, firefighter 3. But you didn't. You called them firefighters. You could have said emergency physician, obstetrician, anesthesiologist, cardiologist, hospitalist, orthopedist, radiologist, urologist, but you didn't. You called them doctors. You could have said CRNA, CNP, CCRN, PICURN, case manager, LPN, CPCURN, med-surg RN, but you didn't. You called them nurses. But you didn't have a term for these guys. You didn't have a term for these guys. We have not given the public a term for these guys. So back in 2011, Mike Nolan was ending his term as president of the Paramedic Chiefs of Canada, and I was ending my term as president of the National EMS Management Association. And Mike and I had seen each other around the world as we went to different meetings, and we got to see some of the cool things that were happening in other countries and the way things were shaping up. And so Mike and I got together in Banff at one of the Paramedic Chiefs of Canada conferences and said, we should leave a legacy behind. We should leave some kind of a legacy behind. So we decided to invite 15 paramedics from around the world that we knew to be really good strategic thinkers. So we sent them an email and said, we want you to come to Ottawa for a meeting that has no agenda and spend 2 days with us. And by the way, you have to get yourself there and put yourself up, but we're going to supply the meeting room. Guess how many people showed up? 15 people came to a meeting with no agenda. And so our aim was to create the first international strategic plan for EMS. As we started meeting and having conversations and talking to each other about what was going on in our countries, I knew the Canadians had made this shift where they went away from the US model in favor of a different model. And I didn't buy into it. I was a paramedic, and I really wasn't all that keen on EMTs sharing that had 80 or whatever it is, 160 hours of training in comparison to the training that I had had. I wasn't bought into that. But I also knew that I spent a lot of time in DC, and when I go to DC, sometimes it's 18 times a year, spend a lot of times with members of Congress. And when I go there and say, we need you to do something for EMS, immediately they say, we did. We enacted the Fire Act grant problem, and Fire Act grant program, not problem, program, and we have given billions of dollars to EMS. And I say, well, that's not really EMS. And they say, well, yeah, they are, because here's the list of things that are EMS, and first responders are right there on the list. Or they'll say, we did something for EMS because we created the hospital bioterrorism program. We've given billions of dollars to EMS because hospitals are part of EMS, and we funded it, now go away. So what the Canadians said was, when they changed their system so that they have primary care paramedics, advanced care paramedics, critical care paramedics that work for paramedic services, and went back to Parliament, they had a different conversation with Parliament. Because when they say to Parliament, we need you to do something for paramedics, or we need you to do something for paramedic services, Parliament knows whether they did something for paramedics or paramedic services. And it's not the Fire Act grant program or the Hospital Bioterrorism grant program. And that changed the equation. So I'm going to let Pierre, I don't want to steal his thunder, he's going to talk about that. But we adopted a structure at that meeting that some of us have spent the last 7 years trying to promote. And this is the structure that we adopted. If you go to internationalparamedic.org, you can download the roughly 13-page document. The paramedic is the professional practitioner. Now, that doesn't mean there's one paramedic, although we might see some country go that direction. That could mean we have 3 levels of EMS providers in the United States now. That means we have 3 levels of paramedics into the future. But it's a single name, single name. So you saw the structure that we use here: primary care paramedic, intermediate care paramedic, advanced care paramedic. But paramedic is on the end of each one of those, and it defines a structure for the profession. The paramedic service is the provider of emergency medical services that is staffed by paramedics, and paramedicine is the discipline and the area of medical specialty and knowledge. Who knows what this is? This is the 1996 EMS Agenda for the Future table of contents. Where are you? You are a human resource. You're not even important enough to have a chapter heading in the EMS Agenda for the Future. But who does have chapter headings? Finance guys do. Public access people do. Information system people do. But you don't even get a chapter heading. You're lumped in with vehicle technicians and mechanics and everybody else that's part of a human resource of an agency. That's not good enough. That's not what we deserve. I went to a rural health meeting in Omaha that the Office of Rural Health Policy from HHS was at. And at the end of the meeting, I was at the Omaha airport sitting in the area waiting for my flight. And Tom Morris, director of the Office of Rural Health Policy in DC, was also in the same area. I got an email from the American Hospital Association, and it said, we have been invited to be on the steering committee of a new grant called the Efficacy of Telemedicine in Emergency Medical Services. And since that must be about ambulance services, we assume you're already on the steering committee and we don't need somebody on it. Confirm. I'd never heard of the darn thing. So I walked over to Tom, whose office is funding this research project, $1 million research project. And I said, Tom, look at this email I just got from AHA. What the heck is this thing? So how many paramedics or paramedic services do you think are part of this research project? What percentage? Well, you might think 50% because you got to connect to somebody, right? But this is the Emergency Medical Services Telemedicine Project. Well, Tom says, well, that's a program where we're evaluating the effectiveness of using telemedicine in having a physician in an urban emergency department consult with PAs and nurse practitioners in critical access hospital emergency departments. That is the efficacy of telemedicine in emergency medical services. Where is our identity? But another federal agency has checked off a box on a form that they have funded emergency medical services. That's not good enough. So as we look around the world, there are some changes. You've heard about some of them here. Things that are going on in terms of regulation of profession and regulation of people and agencies. And so the United States is the only English-speaking first world country in the world that has not adopted the word paramedic for our EMS personnel. We're fast becoming the only English-speaking industrialized First Nation in the world to have not adopted a degree requirement for entry to practice. That's where we are. So earlier this year, the National EMS Advisory Council had a, I forget what they call these now. There's a specific term for them, but it's a thing that the council adopts a position, a position statement. They have adopted the word paramedicine for our discipline and have basically told the federal government to start using those words. They stopped short of adopting paramedic and instead said the feds need to create a dialogue about creating a single term for our industry. We don't need a dialogue. We don't need to be different than the rest of the English-speaking first world countries in the rest of the world. That work's already been done. Tens of thousands of people have been through it, and the other countries have multiple levels of paramedic. We can make the change. So we have a couple of important projects going on that you heard about Sunday if you were here, when the Department of Homeland Security and NHTSA did their introductory things. One of those is work on the EMS scope of practice model. I submit that's an outdated term, and that we should be dealing with the paramedicine scope of practice model, and that we should insist that our government do what their advisory council said and use those words. EMS is not a person, and it's not an agency. It's a system of 15 components. And the minute you try to pluck one out, like hospital bioterrorism program or first responder grants, we have no identity. We have no identity. And you can't pluck, when it's a system, you can't pluck one thing out and talk about it like it's the only thing. Because in the end, what's going to happen to us in the future is what has happened to us in the last 40 years. We're going to be left behind because hospitals are EMS, first responders are EMS, everybody is EMS except for us. So we have a naming structure. It's not a singular word. The singular word is for the collection of people. But the naming structure has multiple levels, just like we have today. We can transition from EMT, advanced EMT, and paramedic into a different system. One of the ways that we could do that is for the scope of practice model to adopt two terms. Because we have 56 states and territories, all of which have their own legislation to do, and some of which have not yet adopted our system from a decade ago yet, we need to have two terms in the scope of practice model. We need to have the existing term and a companion term. And if we just simply write both terms into the scope of practice model, states can decide, agencies can decide, people can decide. But we need to have both terms in there, or no state is going to be prompted to do anything. So please consider making comments into that process and consider what they might be. So we have lots of collaboration going on. As I mentioned a bit ago, more and more countries are making bachelor's degree the entry to practice requirement. It would be really tough here. But you know what? those of you from Wyoming that are volunteers in your agency, if you lived in the outback of Queensland, you would be paid to do your one run a week or one run every 2 weeks. So I don't want anybody to leave here and say Gary Wingro is anti-volunteer, because I'm not. I love volunteers. I was a volunteer when I started my career in rural Iowa. What I am for is us giving volunteers career positions and pay. Taking all of our volunteers and paying them just like they are in Queensland, just like they are in British Columbia. That's what I'm for. The other project that you heard about was EMS Agenda 2050. So the last agenda for the future was 1996. This is 2017. Some of us think it's been way too long since 1996, but now we're going out 33 years into the future. And we're starting from a reference point that is 20 years behind the other countries. And the EMS agenda for the future can't be about, let's think about self-regulation of EMS personnel, let's think about doing something different. That's already done in the rest of the world already. It needs to be futuristic. 33 years is way too long. We need an agenda that's compact, that's updated every 5 to 10 years, but starts at a reference point that's different than where we are today. I think EMS Agenda 2050 has a good name, except for the 2050, because EMS is still a system, and it should be about the system. And paramedics and paramedicine are part of that system. We're a profession and people that work in that system. So that agenda should be about systems of care, STEMI care, trauma care, stroke care, systems of care, and we're part of that system. So I think that's a good title. I wouldn't change that one. So I just want to quickly show you 4 nations. I hope I have these right. I consulted with somebody in each of the 4 countries, but I might be a little off. So first I want to talk about the number of ambulance services by country and give you a feel for what that looks like. So what is that first country? Whose flag is that? Yours, okay. And the second one? United Kingdom. And the third one? Canada, honorary Canadian. And of course you know the last one. Australia has 8 ambulance services. There are 6 states and 2 territories. Peter, did I update that right? Okay. All right. Great Britain has 13 ambulance services. There are 4 countries and 13 ambulance services. Canada has 119. 7 provinces or territories have 1 ambulance service. And then among the rest, there are 112. So 119 ambulance services in Canada, but 7 provinces have 1, or territories have 1. Here we go. We have 19,000. We have 300, more than 300 just in Minnesota. We have more ambulance services in Minnesota than all of Canada, twice as many than all of Canada. That's not good enough. So a little side by side here by population. There you see the population of those 3 countries. Population served by each ambulance company. In Australia, 3 million. In the UK, 5 million. In Canada, 300,000. Any guesses on the United States? Well, let's see. 321 million people. Each ambulance service services 19,000 people. Let's do it by square miles. This isn't kilometers, this is in miles. So there's the 3 countries. Australia, 8 ambulance services. Each one covers 371,000 square miles. In the UK, each one covers 7,000 square miles. In Canada, each covers, on average, 32,000 square miles. What do you think the US is? 200. 200 square miles. That's not good enough. We're not that special. The patients who have a stroke here are the same patients that have a stroke in any of the other 3 countries. So it's time for us to stand up and take ownership of ourselves and our profession. It's time for us to give the public a singular name. Chris isn't here, I wish he was. When we did that meeting in Ottawa, and I had not yet bought into that system until I heard what Parliament did. But Chris and I went downstairs, down on the streets of Ottawa during lunch. And we randomly grabbed people off the street that were headed to lunch somewhere. And we said, hey, we're here from the United States, nice to meet you. We're just curious, what do you call the people that work in your ambulances? And after you got over the look of shock on their faces, what do you suppose 100% of them said? Paramedics. Now, they didn't know if they were primary care paramedics or advanced care paramedics, but do you really think the public knows the difference that you're an EMT or a paramedic or an advanced EMT? The public doesn't know that. Everybody in Ontario knows that paramedics work in that vehicle who has on the side of it paramedic service. This is what a profession looks like. And I'm going to stop here. Pierre, if you want to come up, I'm going to stop here. This is what a profession looks like. This is the UK. It starts at bachelor's degree, and it goes through PhD. We're not good enough. Now, we can't take the whole leap. We can't immediately next year move to bachelor's degree and name change and all of that stuff. It's going to take time. But it's darn time that we started. So Pierre, I hope I didn't take anything away from any of your slides. But once you do your first one, then I'll start your second one for you.
Okay.
Down is actually next. Up is previous. Middle one is pointer.
I would say Gary and I drink the same Kool-Aid. It really is kind of an interesting journey we've all been on. Just that last comment about interviewing people in Ottawa, it had only been 10 years that we had changed the name. So in 2003, it was called the Ottawa EMS, and we changed the title of the service to Ottawa Paramedic Service. And that really was an important piece to move this all forward. I think Gary's, I probably had a half hour to speak, but now I only have 5 because Gary said everything I had to say. I thought I'd say something controversial along the way, but I guess I haven't. That's all gone too. No, a few things. One is emergency medical services is really kind of an archaic term. In the municipal world, it also means emergency management or environmental management services. And that was one of the arguments we used when we changed the name in the city of Ottawa. Mobile integrated health is another term that's, I would say I don't support because it is one of those diffuse set of words that to me doesn't mean anything. I think it's about the paramedic and what the paramedic does. So I call it community paramedic, and that's the only terminology I propose and that I use. The last piece that he also spoke about was the terminology of using the word paramedic. I've always been a strong advocate that it is about the individual. And thanks, Gary, we're absolutely on the same page. I have 2 kind of separate presentations. One is to give you context about what I'm going to talk about second, which is the development of a national standard. That'll be the second piece. So just bear with me on the front end. Just Paramedic Association of Canada is a national organization, and I always try to make this distinction. It's not a union and it's not the management group. It really is solely interested in promoting the profession. So hence some of our strong feelings about the terminology. We're kind of we have about 20,000 members out of about 40,000 paramedics in the country. We really don't know how many there are. It's one of those great missing points. We've been trying to work with different agencies to actually figure out the exact number. But we'll work, that's one of those longer term projects. Our focus really is national and national initiatives. Just to give you an idea of some of the stuff we offer, National Liability Insurance Program, and that kind of seems like a little bit of an arcane piece to throw in here. But it's an important piece because under profession, I believe you have a personal accountability. When I started as a paramedic, I always remember hearing, well, if you make a mistake, it's kind of the doctor's license. Don't believe that. I absolutely believe that I'm accountable for my actions, and therefore I should be accountable to have my insurance. And so that's really kind of an important piece. That took us about 2-3 years to pull that together. And now I think we have over 12,000 registrants with this understanding that I am responsible for my actions. We hold a conference. One of the big pieces of our work is Canadian Paramedic Profile, and I'll talk a little bit more about that. We're involved in accreditation, and we're also involved in research and standards development. Gary kind of set the table for me when he talked about advocacy. Just this year in advocacy at Parliament Hill, I met with the Federal Health Minister and the Minister for Public Safety, and I think we met with 83, about 1/3 of the members of Parliament. And these were the 4 topics that we had on the agenda. Community paramedicine was first. The health and wellness of paramedics was number 2. The opioid crisis, which really is a crisis in Canada and in many different jurisdictions. And also we had this idea of how we're engaged, and it's kind of alluding back a little bit to what Gary was talking about, that we want to take our place within such specialized areas as heavy urban search and rescue. This wasn't about getting the fire service money. This was about recognizing the paramedics' role within HUSAR, specifically the health and wellness of the patient, but also of the workers. So that was our advocacy for this year. Next year, we'll probably have 2 or 3 of the same as we move forward. There's a comment earlier about self-regulation, another primary reason that the Paramedic Association of Canada exists. There are now 5 provinces that are at the point of self-regulating. And that really is, once again, comes back to personal accountability, professionalism, owning your own responsibility for the actions that you take, but also defining your profession, defining what is your unique body of knowledge. So Alberta goes back to 1987, but in 2016, they came under the Health Professions Act. And what is unique about that is that they don't allow for any subdelegation of authority, which really was an important nuance. In '87, when paramedics were under the Health Disciplines Act, there was still this kind of quasi-understanding that medical direction still led what they did. In 2016, under the Health Professions Act, there can't be a subdelegation of medical acts or restricted activities. So the profession is uniquely responsible for that, which really means that the individuals, as in the individual paramedics, are responsible for their own profession. Medical direction is evolving into medical advice, medical advisor. I want your opinion, but that doesn't mean you tell me what to do. Really an important nuance. New Brunswick, Saskatchewan, Nova Scotia, and just recently Manitoba is in a transition council period. This is kind of a complicated slide, but this is, sometimes you have life's work. I'm absolutely dedicated to baccalaureate education for paramedics as entry to practice. Part of one of the reasons why I got to the point of becoming a disciple for this really was the fact that as the service that paramedics provided changed from strictly urgent care, where you had a narrow body of knowledge with a fairly deep understanding, to providing public health services, where you have to have a much broader understanding of health services. That is really the transition from being, to me, at a diploma to a degree education. So this slide just shows that in 2016 at the top, we redid what the Canadian Paramedic Profile is. We redid a scope of practice and a code of ethics for the profession. We're actually in the second iteration of a curriculum guidance, and then we're working on the other part with an assessment guide and accreditation processes. This is all about building the argument for baccalaureate education. There are a few programs in the country right now, but we really have to keep moving this forward as a long-term project. These are just some of the people that we have to work with. The reason I use this one is that it's kind of a mess, because as much as we think that we have consolidated the terminology in Canada, that everybody believes in all of these parts, there's outstanding little appendices that still exist. So the National Occupational Classification, which is used by the federal government, still has EMT and several other versions of EMT in it. So we have to clean that up. They consider paramedics as non-professional health providers, so we have to clean that up. And these are all the other pieces that have to be lined up within this. So when I come to community paramedicine, and I'll get a little bit more into it in the next set of slides, but currently primary, advanced, or critical care can provide the service. And the education and support of what they're doing is really an adjunct. So it's post-diploma education. Is it consistent? No. Is it probably specific to the needs of their communities? Yes. Does it have the depth and breadth that's required to provide safe practice all the time? Probably not. And once again, that comes back to having a more fulsome education. So we have work to do. Where we're going to be with baccalaureate education, it really is going to be 100% of PCP and ACP, the advanced and primary care, and probably portions of critical care. There may be portions of critical care that fall out. And sorry, one last thing there is that truly the baccalaureate or the community paramedicine will be within the standard education. What will fall out may be other specialties, which you can't always address. So much like other professions, they oftentimes have specialties that are outside the baseline. You do have specialty nursing, and we're intending to have something similar. So you've seen this before. The other reason for baccalaureate education that I really think has always been important is the fact that we haven't been able to define what is unique to paramedics and also create our own research and create our own knowledge. And without, and I'll think back to the 90s when all of a sudden it became sexy to study and do research in the out-of-hospital area, 100% owned by physicians, and sometimes they had a paramedic. In the early 2000s, you started to see paramedics become involved, and usually when a paramedic had gone to school for some other reason to get research methodology or some other degree or recognition. We have to get to the point where we're actually defining our knowledge base of who we are and what we're doing. And the UK really did a fine job of this, and I think every country should recreate their own of this, of what is the laddering within these 4 specific domains of practice, management, research, and education. Really becomes an important nexus for all of the work that you do. That you have to have baccalaureate trained paramedics as a baseline so that you can have your master's and your postgraduate at the PhD levels to actually really create and own the profession. So that was just the front end. It really was kind of an important piece just to start that as where our profession is and where we're going. Thanks, Gary. With respect to community paramedicine, there's kind of an interesting road of how we got there. And, I've really been, I think, I wasn't at the first event in 2005, I think, in Nova Scotia. I think I was at the second or third, and I've probably at least the 5th or 7th time I've been to one of these. The level of discussion has really evolved in a very positive way. And you can kind of really start to see that we've really matured in what we know about community paramedicine and its application, but also an understanding that this is not a short term, that we have to transition from pilot to program. And that really is one of our huge challenges. And some of the other speakers have really been, quite eloquent in the presentation that we have to move to the program concept, and that now we have to conform to other people's constructs to get there. It's not just good enough to have the good idea, it now has to have what is robust to make it sustainable. So we partnered with a thing called the CSA Group, also known as the Canadian Standards Association, and they are one of, I think, about 8 standards development organizations in Canada. I think there's about 300 in the States, and this is everything from NFPA to ASTM to all the other ones that you have in the States, and I don't know. We have essentially, 8, but 4 that are their primary. CSA is one of them. They're involved in many different areas. They're, a solid company. They're a not-for-profit agency. They do an incredible amount of work. But what they also do is they belong to the Canadian Standards Council, which actually also adheres to the international standards organizations. So all of that kind of links back that there's something that is solid as a platform in terms of process about how they do things. And a really kind of an important piece. So these are kind of the base principles of all standards organizations, that there's transparent, that it's multi-stakeholder, that you actually are looking for the dissenting opinion in the makeup of your committees, and really kind of an important piece in terms of a partner. I go back to the Paramedic Association of Canada now. We're really kind of, once again, a national organization looking towards recognition in healthcare legislation, and also really in terms of improving quality care for Canadians. So how do we get to standards development? Kind of an interesting road. I think it's been quite fascinating. We developed a national profile, which came to be in 2001, and it was the sum of the knowledge, skills, and abilities of paramedics. It was just short of being a curriculum blueprint. So it also had competency areas, sub-competencies that really were detailed. Plus it had performance environments, which made the education process, I would say, fairly arduous. There was a recognition that you demonstrate competency, and we can have another chat about that. But the document really did change education, and it really kind of augured in the future of this thing of primary care, paramedic, advanced care, and critical care, because we standardized the language in this process. We didn't stipulate what the education in terms of length had to be, but it really did move the length from being arbitrary and moved it towards, a minimum of 6 months at primary to 2 years. And we're kind of settling in at the 1 to 2 year for primary care paramedic, and then advanced care being another year. So you could say primary care paramedic is now almost at a diploma, depending where jurisdiction you're at. Advanced care, advanced diploma is what we're at. The Paramedic Chiefs of Canada had a white paper in 2006. It was actually called EMS, I think, of the future. But it noted the fact that care was evolving from being strictly urgent care. So it kind of said, hey, what about community care paramedic, without getting into it, but also said that you better start doing research. And that was one of the thrusts of this paper, was talking about the need for research and what we do to prove what we do. We renewed the profile in 2011. It was just a tweak, but an important tweak, because we added public health. And when I say public health, it's the spectrum. It was very narrow in scope, but it was just kind of the wedge in the door to say that we're no longer just urgent care. We are much broader than that, and we're into public health. So there's some neat things that happened. First, so every one of these pieces, I think except for the white paper, we were able to garner funding from federal or provincial agencies for them. What was next was that we got funding to do a paramedic standards development framework. And essentially what that document said is, where are all the areas where paramedics don't know about what we do? And it's a long list, because we don't really have standards in so much of what we did. And I remember in Canada for the longest time they were using the 1962 KKK standards for ambulances. Rings a bell? I don't know, something like that. But so we took a look at this and said, look, there's all of these gaps. So let's put this out there. Let's get somebody to write it up. And we wrote it up and said, you know what? This is going to be one of those foundational pieces that says, we have gaps, let's start to fill in the gaps. What was key about this is this became, you know, the photocopy in every submission that went forward to government for something that you wanted. You have a national research agenda, you have a gap analysis, and now you have a standards framework. So now you're saying you're going to give something back that is tangible. It isn't just the fact that we tried this new piece of equipment and it works. We're actually going to start working on standards frameworks. Also in that, we started listing our research priorities. And this was a group of paramedics across the spectrum came together and started listing research priorities. The standard, community paramedicine standard, we just completed it, and it's now available, and I'm going to come back to it. But it is one of 3 documents that we have in the works right now. We got a separate funding from a provincial agency to develop the psychological health and safety standard for paramedics, which builds upon a broader standard for just in the workplace. And we also have vehicle standards that are coming out. So all of these have kind of, you know, it's kind of the thing is that you're building your credibility, which allows you to access even more. So the standard itself, the community paramedic standard, we brought together a whole bunch of groups, you know, and the principal ones are always the chiefs, PAC, provincial regulators, service operators. The interesting part here is we brought home care in as one of our initial partners. When I talked about the framework by which standards development agencies have to work, they call this thing a balanced matrix. Normally I like to just get all my like-minded friends together to decide things, but they didn't allow me to do that. So what you have to do here is that you actually establish categories, and you need 4 to 7 people per category. So we ended up with a group of around, I don't know, 28 people. And the thing about it is that it isn't just your like-minded friends, which becomes a challenge, but also adds to the credibility of your final product. Really an important piece. We also brought Gary in as a friend, as an international friend, to help us with this, so that we could access what's happening in the States. And that seems to be kind of a really nice introduction that makes that the standards development is broad-based. So these different groups are all invited. We had a group of about 28 people. We had a scope document, you know, in terms of what our purpose was. And once again, this was about developing a framework for community paramedic programs. The scope was that it was a systematic approach, and we kind of tried to keep that narrow to that specific scope. The important piece here is to recognize that our intent wasn't to tell people what to do or how to do it in terms of being overly specific. We're providing you a framework of all the things to consider, which really was an important piece. It's not a management standard, it's a program standard. So if you were to say, at the end of reading the document, you were to compare your program to this standard, and you were to establish a checklist, it would be an interesting exercise to do, because as I've listened to the discussion over the last couple of days, a lot of what people have talked about really is all the check marks within what we're talking about. And I have, this is just the content page of what's in it, and I'll skip that because this is one of the probably 2 key slides I want to talk about. And this first one really is, if you were to go through all the presentations over the last couple of days, you'd probably see that if you were to take all these elements out and put a little tick box, yes or no, I bet you most people would have hit most of them. And that's really what it is about, you know. If you work your way around the circle, you know, are you looking at it first from, are you patient-centered? Are you collaborating with other groups? What is your evidence? And then you work your way around. And then as you work around the inner circle, it was kind of nice to hear some discussion about triple aim, because that isn't the paramedic language, excuse me, it's not the paramedic language, but it is the language of others that has credibility. Really an important piece. So this kind of process, I think, has been really important. And you know, the neat thing about it is that it's not anything, I don't think it's anything overly onerous. And the other part that's, you know, in a very nice way, it's disappointing that it's not anything new to most people in the room. So in a way, it's a consolidation of what most of us, or most of you, have been doing in the room. The other piece was to take a look at, and this was the reference to models of care, was just this slide of saying, what are you looking at and what are you wanting to do? When we've tracked the folklore in Canada about community paramedicine, we go back to 2001 of Long and Briar Island, a little spit of land in the Bay of Fundy off of Nova Scotia, and they realized they couldn't get a physician there, really couldn't get a nurse, and they said, well, it's 2 ferries plus 45 minutes, why don't we stick a paramedic there? And that was 2001, and that was kind of our initial, the seminal event in Canada. And then all of a sudden I hear of paramedics in Toronto, downtown Toronto, trying to defer 911 calls. Wow, this is like chalk and cheese. But the idea is that these kinds of ideas fit into this program or this concept of what is the model you're looking at. So you extract that back and then you put it back into the slide before and say, are we meeting these kinds of concepts or needs? So, over the process of the last couple of days, I kind of look back and I think of a few items that in Canada we have, and it's because I've touched on, people have touched on this, we have non-exclusive scopes of practice as a philosophy. So when paramedics start moving into a field that was, say, traditionally of another profession, we haven't encountered the resistance that others have maybe. So that's an important piece, that we have essentially non-exclusive, because as legislation has changed, it's become much more permissive for anybody with the demonstrable competency to provide that service. So we haven't made that. Second thing to note is I've heard comments about competition in terms of labor. Overall, on the Canadian landscape, there's a shortage of healthcare providers. So when you add that to the part of non-exclusive, whoever can put their hand up who can do it usually already has their foot in the door, an important piece. Yes, sorry, and those are just 2 concepts there. When I went back to the slide before, a couple other things that are unique to Canada is that I was talking with, I think it was Bill earlier and someone else, that we have a single payer system for the most part. And the idea of starting with a concept or a project as being financially motivated, or with the financial component being one of your initial thoughts, is kind of not a Canadian thing. I would say that most programs that I've been involved in has all been about somebody's got a great idea, how do we make it work, let's get it running, and then we'll figure out if somebody can pay for it. So that's kind of an important nuance for us to also know. No, and that's probably the sum of what I want to bring to you today. You know, I applaud the group and I applaud everyone in terms of saying that this has come so far, and the quality is, we can see that we're just at that kind of, that linchpin of moving from projects to programs. And that really is truly, I think, to the benefit of patients. And I'm absolutely motivated by that. So thanks for your time.
All right, can we get our speakers from this session back up front? Okay, question and answer time.
Yes, I just have a question about the bachelor's degree in the paramedicine. Now, on some of the slides, I see all of the courses that are put up, but in where I'm on the university in St. Louis, bachelor's degree has 128 credit hours. 64 credit hours are what were called gen ed hours, which can be humanities, math, English, science, all those kinds of things. So is that something that's part of this curriculum too?
If I was to say a simple answer, I'd say yes. Two parts. In Canada, there's oftentimes this thing called applied degrees. I'm not into that. An applied degree has an endpoint, which means that you don't have direct access to master's education. So the construct here is a recognition that if universities require 64 credits in the humanities, that's a requirement. So the whole building, and that one slide where I showed the profile of the competency profile for paramedics, we've stolen the construct from the Royal College of Physicians and Surgeons about how they wanted to do their education. And we're making use of that construct with competency-based education. So that really is the foundational piece, and the educational piece will only allow, I'll say only, is made to allow for the advancement to postgraduate degrees.
First of all, Gary, it wasn't clear what you wanted to call the people on an ambulance. Actually, for the folks from California there, the statutory scope that you addressed, being successful with paramedics in the field, the battle legislatively between the nurses and the paramedics in California was pretty well publicized. How do you plan on moving forward from the pilot?
Well, there are two pieces of legislation that have been introduced. One of them by the California Ambulance Association, and another one with some mental health. Yeah, mental health. One of them, the mental health one, obviously is dealing just with alternate destination mental health. The one from the California Ambulance Association tries to pull in the other concepts. In my opinion, both of those bills that were introduced last year are inadequate. And one of them slipped through the Health Committee by one vote and is now sitting in appropriations in suspense. And I believe that those bills will come back up in January. We continue to work with our, as we call them, our naysayers. And we have made some movement given the results that we're seeing. And with the elimination of the alternate destination urgent care concept, which we are bringing to a stop in the pilot, therefore it won't show up in legislation, will help with some of the negativity we were getting from the CNA. So, but we still have a long road to hoe. And again, a pilot can only go on for so long, and I think that we just got an extension of the pilot to take us through November of 2018. It's my opinion if we don't have legislation by 2018, that the chances of getting another extension on our waiver could be a difficult fight. So. I'm sorry? If we don't get the legislation and the pilots cease, the community paramedic program cease. As tough as that is for me to say, since I've been living this since 2013.
I'll ask the question of both Pierre and Charles, and I could probably ask Gary as well. Pierre mentioned the importance of research and paramedics owning their own research. When are we likely to see paramedic journals, professional journals, not magazines, in both Canada and the US?
Well, I would say that if you get a chance to see Scott in the exhibit hall, that's the first one to talk to. We have been contributing, but we have not owned our own industry. So that is one of the weaknesses of paramedics as a whole. We tend to want to tag our name on, or a lot of times we'll do the work and have a doctor's name on it to get it into one of the more prestigious journals. But we do need not only our own journal, but we do need to step up and do our own research and just keep our names on it, keep the docs off of it.
I think for the paramedic community in Canada, we've been engaged with Alan Batt, and I think it's the Irish Journal. But once again, there absolutely is a gap there from us having our own peer review processes or publication.
And Peter, I would have to say, you know it's a mistake to issue a challenge to me.
I'm curious, for the Canadian paramedic, what level is the bachelor's degree required? Is it at the, I'm sorry, I'm rummy right about now. Is it the advanced care? Okay, sorry.
It will be it'll be the sum of all advanced care,
Okay.
Which will then be inclusive of primary care, and it'll probably have components of critical care. But coming to the other comment is that we're going to extend the breadth of education with humanities and really have a recognition of, and I usually start with the social determinants of health, because I was never taught that when I was in school. So.
Okay, thank you.
I'm sad to hear the problems that fund these magnificent programs are constantly, the funds are constantly at risk. The programs are also constantly at risk. And I would love to see if there's any activity going on in the roundtable community, outside of that, to allies and other associations, to try to solve this as fast as possible through perhaps reaching out to the private sector. The private sector benefits from a community that is resilient because of these community paramedicine programs. Many of the private sector companies benefit from the reduced utilization that comes. Some of those companies are self-insured, and many of those companies have pensions that are being depleted because of increasing insurance premiums. And these roles and goals and I would say accomplishments of community paramedicine impacts those pensions and those private sector partners in a profound way over time. I think there might be today a call for us for our next roundtable to put together a team that thinks about how do we build sustainment funding for these programs. And if maybe there's already something like that, and that's the question. You know?
So there is a model. I've actually built a business case on it. It's called Concierge Community Paramedic. There are other opportunities like that out there that could be done to solve the problem you're speaking of. But more importantly, I think we need legislative action to cement that we are community paramedics and this is our scope and this is what we need to be applied for. And unfortunately, we're just now getting around to getting a rule modifier being permanent for EMS. So we got a long way to go on the legislative road.
Yeah, I had a quick comment on that one. In Ontario, the government was giving project funding, and it did it for about 3 years, maybe 4 years, and then just this year they made it part of program funding. And I truly believe that the reason why it went from project to program had nothing, well, it had two parts to it. One is that there was a body of research that we developed in terms of a number of research papers that supported good outcomes. But two was, and you never can discount it, was politics. That we kept the pressure on in terms of the senior leadership, the Minister of Health, to continue to remind them about the goodness of what we're engaged in. And really that was, I think, what clinched it was truly was making it part of the political agenda.
Okay, we are definitely getting out early. We have one session left. It's 20 after 3. How about we take a 30-minute break? Start in again at 3:50. We'll do our last session. What's that? You want a 15-minute break? Okay, all right, so let's start at 3:35. Run this thing in. Okay, everyone, we're ready to get started. If you want to take your seats, we'll get started. Hello, is this on? We're going to get started now.
Okay. Attention,
Break has
everybody.
ended.
We're about to start our final presentation. Probably shouldn't.
Okay, so this is our final presentation. Thank you all for coming this year. We hope to see all of you and 5 of each of your closest friends in Auckland, August 6th and 7th at the Hilton Auckland for the 15th IRCP. And now I get the chance to introduce my second and third most favorite women. My daughter Allie isn't here, but Ann and Mary, I get to spend a lot of time working with them, and they're going to walk us through leading the development of the profession.
So I'm going to see what the mics do. I don't need double mic for a second. Is that okay? Can you guys hear feedback with this one on at the same time? So then I'll just move it over. Does that work? So before I forget, your evaluation forms, hope you've been filling them out along the way. We need to have those turned in before you leave today. If anything, just put them in a pile in the center of your table so we can pick them all up when we're cleaning up. And then also make sure that you have signed in every single day so we can get your CE sent out to you in the next 3 weeks or so via email. Questions on any of that stuff? Awesome. Oh, and all of the presentations right now are already uploaded to ircp.info, and then within the next week we'll have all of the videos uploaded by session number in the same location. We will make sure that the brochure is uploaded so you know what like 14B11 really stands for. It's crazy. It's Gary's crazy numbering system for all of our conferences and sessions, but we'll make sure the brochure is there so you can know to select your favorite one, which is 14B11, of course, right now. Okay. Do you want me to okay. So, with that said, we told Gary that Mary and I have been working together on a top secret mission thing, and we wanted to unveil this at the IRCP conference, and then we're also going to present this in more depth on Friday at EMS Expo. But of course, he saved the best for last, is what we think. So for those that don't know me, my name is Ann Montera, and I am from Gypsum, Colorado, a little place, Eagle County, Colorado. There may have known of 1 or 2 places there, such as Vail or Beaver Creek. We did host the IRCP conference in 2010, and I, at the time, was a public health nurse manager and had this crazy chief come knocking on my door and said, I want to start this community paramedic thing. Little did I know that I'd be standing here, oh my gosh, 8, 9 years later and saying, what the heck did we do and what did I get myself into? So I helped Chris start up one of the first rural CP programs in the United States, and we've been participating, helping out with this conference ever since then. And then you're going to hear a lot about where our passion lies, which is advancing the profession of paramedicine and community paramedicine. Yeah, you can do that.
The hat I'm going to wear today is Paramedic Health Solutions, and my background is critical care transport, and developed that passion for paramedicine and community paramedicine during those numerous years in critical care transport. And met Gary and Ann, and it all started and ended right there because we kept going. The other group we'd like to acknowledge on this screen is Creative Elements. We couldn't have done a lot of our creative work and our websites and everything that's been done without them. and that's Robert Feltner and Mike, and they're both in Cincinnati today.
And I probably should have mentioned I am from the Paramedic Foundation, which is co-hosting this event with the SAVIC Foundation, and I am their Chief Operating Officer at this point, or I like to call myself the Chief Cat Herder, but that's kind of where my expertise lies, keeping all the emails. Listen to all these presentations and all of the programs and everything that you guys have done to get community paramedicine to where it is today. And it's come so far, and we had a vision and outlined, hey, we would recommend that if you decide to do it, that you might be successful if you do it this way or that way. And then you guys are coming out saying, hey, that program that did it that way didn't succeed, but we're succeeding because we did da 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 da. I'm like, oh, they listened. And it's just really neat to see how, not only in the United States, but across the world, that this is, we're evolving together in the United States really is getting things lined out to compete fairly with all of our partners outside of our crazy nation that we have here. With that said, we are going to go over 5 essential key elements that we think are going to summarize where we are and then show you what our next steps are, us as an industry and within community paramedicine. So we call them our 5 A's, and we're going to go through these in some detail, explaining a lot around the education piece, but it's going to just kind of take you to this final point where I think we're going to position this group and then challenge others to go to that next step of professionalizing this industry and everything that we're doing. So we'll go through the academics, see how they are applied with all of that and implemented. This crazy idea of accreditation and advocacy, and then what is that advantage to move to the next step and see where that takes us. So we're going to start off with Mobile CE. And I think the first thing for you guys to know is Mobile CE is sponsoring and doing all of your continuing education hours for this. And we've started launching multiple courses, but I'm going to really look at this as this is the academics of our 5 A's that we're going to kind of dive into. So the first thing that I like to do, and Gary always has this conversation at the beginning of IRCP about the naming of how you name your titles of your providers and having that single nomenclature that we're all in the same on the same page. But there's something that I think that I'm going to start to do at the beginning of IRCP, and is to define the difference between education and training, because they're absolutely different. And some of you probably have already heard my example that I'm going to give, but a very, very, very dear friend of mine, Baxter Larman, after teaching the course in California with UCLA together for the statewide CP course, he really defined how this was different. And people seem to interchange it, but to me it's definitely not the same. So I'm going to give you some examples. I see, training being more hands-on. You're going to go do a CPR course, and education would be more like the theory behind why I'm doing such compressions, or where did that concept of CPR actually get us to where we then did the hands-on training to implement CPR. So knowing, those could be interchanged, maybe, maybe not. So this is an example where I would say you probably wouldn't want to interchange the terms. So I have a 13-year-old wife. We have 4 children, 13, 16, 19, and 23. Household, they were all living with us this summer, lots of fun, and then 5 dogs, a cat, and a rooster. No, just kidding. But we had lots of animals, lots of kids. But our youngest 13-year-old boy, he is in middle school. So he comes home with a permission slip. They're required to have this. Can you please sign this? Because we're going to talk about sex education and maturation, and you have to sign off and agree that he can be involved in that discussion. But I think that I would be hesitant to sign it if it said your son is going to be undergoing sex training in school this week, or are we okay that he's just learning the sex education part? So, it definitely is not something that I want my son to be hands-on trained. I want him to more know the theory behind why he shouldn't have sex and everything to do with that. So that's a little example. So next time you start inserting the words of training or education, think about that and that they are entirely different. So when you're looking at the education, we all know in the basis of EMTs and paramedics, and I'm going to universally use the term paramedic for all levels across the spectrum of care, but already before this crazy CP idea came to play, we knew that paramedics had the expertise, the know-how to deliver care in a moving vehicle or in a home out of the element of where no one else wants to deliver that care. They already know the neighborhoods where their patients are, who needs the most help, and all the resources that are out there. So through this targeted piece of information, we knew that this idea of community paramedicine needed to ensure that not only were they trained, but they had a huge education program that they would undergo to be successful. So because of that, we developed the International Standardized Community Paramedic Curriculum. So the history of where this came from, in 2007, North Central EMS Institute, which is now the SAVIC Foundation, and then in junction with the Paramedic Foundation. This is one reason why we're having this talk, because all these acronyms and all these people, we're just gonna go into one word and one thing. But they all came together and wanted to outline the history of where community paramedicine came from, wanted to establish a curriculum framework, and really be able to collect stats and to monitor how often this course was being taught and in what way, shape, or form. So what we did is this group was brought together, and they created the framework based on the community health worker initiative, and just adding that medical piece onto it. And they wanted to make sure it was competency-based. It wasn't just going through and reading all theory, which it does have a lot of theory. We wanted to make sure that eventually we could come up with an international registry of tracking all of the community paramedics and programs, educational programs, and actual practicing programs that are around the world. We wanted to make sure that we could monitor and distribute the curriculum and keep it updated and fundraise to make sure we're changing and developing and improving as this program was developing. And then possibly even create like that job board. I think the first time I ever saw an ad, and probably was in EMS World, when they said there's a job posting for a community paramedic. I'm like, finally, like they're there, they're a real person, and people are wanting to hire true community paramedics. But so it's starting, but now what if we could have one central place for everyone to go just to hire community paramedics? And then how do we ensure patient safety and ensure high quality of programs and providers, but to ensure those standards are in place, and then of course the distribution of the curriculum. So a group came together through those foundations and back in 2007 and had this vision. So 10 years ago, they saw 4 levels of what the education path would look like. The first level being more like the non-paramedic, like a couple 2-day type of, or it could be a couple 1 or 2 hour type of lower level course. The next one would be where you would receive an associate's degree with it, or part of your associate's degree, or you could get a certificate upon completing a community paramedic course. The third one would be a bachelor's degree. So if you were getting your bachelor's in paramedicine with an emphasis on community paramedicine, that would be one part of that, or it would just be a part of the bachelor's in paramedicine degree. The last and final one, because of remember it's an international curriculum, and that's what they were thinking in 2007, we wanted to ensure that our partners outside of the United States who require the bachelor's at the minimum entry level would have a place for them to advance to a master's degree. And I know that that is going on. You guys have heard about that work already over the last 3 days. So 10 years ago, these were the 4 stepping stones and the vision of what they wanted this curriculum to look like and where they saw it going in the future. So the first version of the curriculum completed in 2009, completed in 2007, and they felt at that time you were receiving a certificate upon completion for a non-credit course, and hopefully, if not an associate's degree, it would help you achieve that associate's degree. So the first course was taught in 2009. It was taught in Minnesota. There were 12 students. Dr. Wilcox, there's my favorite doctor who taught the very first CP course, and his 12 students did through Hennepin Technical College. They had that hands-on time with him. All their clinical time was with Dr. Wilcox, and really going through and figuring out, here's our 100 hours of hands-on skill, and then the clinical time varied depending on person to person. One thing, upon completion of that first course, there weren't any programs that they could go and start working in yet that hadn't been developed. So for once, education was ahead of their time, but second, they were just sitting there waiting and anxiously wanting to put all of those, that new education to work. So then in 2010, we in Colorado put together a group to do the second course. And so we call this the 2.0 version. And there was a little update from the first one to the second one. So people will call this the 2.0 version, where I took the modules that I had created, we tried to prioritize what we were going to do with it. And we formed a committee based and adjusted it based on what our community looked like. We did add a huge lab component. When I was trying as a nurse to teach paramedics about theory, they're like, Anne, this is all good and fun, but when are we going to actually touch and do things? Like, this theory stuff doesn't make sense to me. So definitely that lab component was important to be added, and then we found a way to track the clinical competencies as we went through things. So we did 2 phases of this. The first phase was some clinical time and all the didactic piece. And then like a year later, the community paramedics that actually completed the course, because all of them just kind of wanted to test it out and see what it was going to look like, did those additional clinical hours based on how the program was developing in that area. So after that, we realized that this curriculum, it had that basis of the community health worker, but needed more organization, more goals and objectives to be standardized. So any college or university that would pick this curriculum up, we would know that we would ensure that they're teaching a very similar program across the world. So we also knew that it needed more of an educational format with goals and objectives and lesson plans. So we put together a team that helped us raise the money and get it to its current version of where the curriculum is now, which is the 3.0. I always like to name out and acknowledge who sponsored this. In the end, and as of to date, the federal government has funded about $150,000 towards the curriculum development, which, you know, when you say, is the government really involved in the evolution of CP? Well, they've been funding it, whether they know it or not. So they have been, you know, involved, and really our rural health centers have been crucial with that. And also just the SAVIC Foundation has contributed those dollars as well. So when we finished the third version of the curriculum, we felt that we had created an educational model that was more like a 300 level course. Now, did that mean that you had to take it in as part of a bachelor's degree? No, but it meant that taking it with some college experience helped it to be more successful. We've seen people take this since then and try to put on a 16-hour course, and they're like, yes, the 16-hour course is all we need. Guess what? The program's no longer in place because everyone was failing the final exam and failing this exam that we'll talk about in a little bit. So, but what it was a piece that also helped you elevate your professionalism and your educational blueprint of where then you could advance your career in any way, shape, or form, even if it's just beyond community paramedicine, but being more that healthcare professional like the other countries that are sitting around the table. So ticking along, and after we taught that, we've been teaching that, we've had a team together now for 1.5 years to update it to its 4th version. And so I'm gonna go over what we're working on, how it's evolved from 7 modules to the 12, and what that outline is. So first, this is our update team and everyone that is currently working on it, and of course, Mary, Paramedic Health Solutions, and other people that are around the table that it helped with our first version, and then some new people in here. We did bring in diversity of a healthcare economist and other people that were interested in making this happen, and you're going to be able to see what this looks like here in just a minute. So these are our 12 modules. Some of it was different than what anybody has taken around. Who's actually taken the community paramedic course to date? Anybody? Some? Brenda. Sorry, when I know you, I could name you out in the audience. So we went from the 6 main didactic modules, the 7th being clinical, to now we have 12 modules. and each of them having a lab and clinical component to it. So very similar to how we do things in nursing school. When you do a pediatric course, you do pediatric didactics, labs, and clinical time, and this is somewhat of the same. So I'm going to quickly go through what they look like. The first one is back to the introduction of community paramedicine. What does it mean? How do you interact with the different healthcare providers? And when we surveyed people as we've gone through this, just even in the United States, paramedics didn't know the difference between Medicare and Medicaid. So, you know, being able to understand how to navigate through the different healthcare systems, whatever country that you're in, we thought that was an important component to add to this, and that's where the healthcare economists came into play. The second one was a systems of care. This is really understanding public health, primary care, how you interact with these different systems, going from working with just emergency room nurses to public health nurses. I know we're crazy and we do more than just give shots, but you know, we are our different breed in every way, shape, or form. Working with primary care, how many of you with your 911 system actually interact with that primary care provider? And you would probably say nil to none, or do they probably even know that what paramedics do in the first place? So interacting with them just to get to know EMS and then community paramedicine we felt was really important. Then we go into the social determinants of health. This is the same of what we had before. We just kind of reorganized this, and I always call this as your biopsychosocial spiritual well-being of your patient, understanding anything and everything that can impact that care of your patient. The fourth and the fifth used to be our community module, and now we split it into two modules, one being the operations of a community paramedic program and one being the interventions that the community paramedic does in their area, and understanding how to refer those patients to all those different community activities and resources. On to the sixth, cultural competency. Again, I'm still pushing and pushing that this needs to be part of our core paramedic education. It'll get there someday, I know, here in the United States. But again, this is very crucial when interacting with patients in a different manner, spending more time with them, knowing how to communicate with them is really important. Going on to Module 7 was the personal safety and wellness. This is the same as it was, really emphasizing more about what we're doing and adding more with the burnout that our CPs are seeing, the compassion fatigue. When we went through this and taught this in California, they were our first set of students, all 77 of them, and we said, you know, you're gonna reach this point when you're gonna just be overwhelmed by everything that you're giving and giving and giving to your patients. They're like, oh, we already do that as regular paramedics. It's entirely different, and I bet there's some of you around the room that are seeing that. But this we felt was really important, and we have now added it as continuing education for those who haven't taken this part of it. The eighth one, we put all the chronic diseases into one module instead of having that broken out just within the clinicals. It is important that no matter what program that you take, that you still need this baseline information about chronic disease management and all of these main modules no matter what. Keeping in mind, you can't just cherry pick what modules you want to take, because you have to be able to have core competency and ensuring that quality of care and across the baseline, and then you re-emphasize what your program is going to be based on your clinical experience. So we added 4 additional modules. Mental health, very crucial, not even needing to explain why that needed to be added. A whole documentation module, since your chart system is entirely different than what you do as a 911 medic, and then outreach education, and then we had a whole older adult series of 6 modules that we put together. So in the end, this is what we are expecting this to look like. Again, 12 to 16 weeks, around 100 hours of didactic time, 100 to 200 hours of clinical time over a semester in length. And based on your experience and how long it will take, and that is all competency-based. So I don't always like to put time and hours to everything, because I think we should really shift to that competency-based learning. There's our credit hours. We're seeing currently between 12 and 14 hours that people are getting awarded for this, which is helping them with their associate's degree or even their bachelor's degree. But we're also seeing probably more non-credit courses at this time, so we're hoping this will help them get there. The other thing that Mobile CE helps us out with is being able to take the prerequisites needed that we're recommending that would be helpful for you to have in place, since across the United States, for example, every state requires different prerequisites, have different hours of education for paramedicine itself. So without some of these, we're finding that the students aren't as successful. The other thing that we are introducing with Mobile CE is the Bridge to CP programs. So every one of these type of allied health professionals or healthcare providers can now do a bridge to become from a nurse to a CP, social worker, et cetera. So that's the list of what that is, and those options are available. They will be coming in 2018 available on Mobile CE for this to be done and taken no matter where you are. We are really seeing Mobile CE as being that one partner that helps you be able to take this no matter where you're situated around the world, and then that clinical time we would coordinate with a local college or university or training center in your area to help get the clinical part done. So really advancing the paramedicine career is kind of what we're gonna now outline going forward. If you really look at, we're gonna go through the different levels of where we've seen, and you guys have already heard it over the last 3 days. Again, this is our recap presentation of the last 3 days. But going from that primary care provider to the advanced care provider, and with that, coming into all these different levels of where we see the community paramedicine profession going. So starting with the primary care paramedic, and then mimicking that is the primary care technician, and then going into the advanced care paramedic, and then the community paratechnician, the community paramedic clinician, practitioner, advanced practitioner, and consultant. And I'm gonna go through those stages again. I'm gonna go through them pretty quickly because you guys have already seen them. But really overlapping the entire curriculum, there are different levels for different types of programs. For example, in Colorado, we have a fire service model where they didn't feel they wanted all that additional education, and the work they were doing alongside other healthcare professionals such as a nurse, a social worker, et cetera. So that technician level would be very adequate for them to be able to have that base knowledge, but still working within their scope of practice, or as an EMT, any. So back and forth, no matter what, though, we are establishing the continuing education path for each of these levels as well. With that, there are going to be requirements with a certification exam for those CEs, and this being the first conference where Mobile CE is offering the continuing education hours for this part of the conference, and then in the future, Mobile CE will be the continuing educational provider for the CP track for our EMS World Expo. So you go through your course, don't lose your certification by not doing your continuing education. We feel that's really important. So here's